Is it okay to start?
Yes, please.
Okay, thank you. So good morning, good afternoon, good evening for everyone in different time zone. Welcome to our third Skullbase webinar series from the Skullbase Division, Universitas Padjadjaran, Bandung, Indonesia. Today, we are very honored to have Dr. Gentili as our virtual visiting professor. I don't think I need further introduction for Dr. Gentili. He's a professor of Skullbase and Neuro-Oncology in Neurosurgery Division, University of Toronto, Crean Hotson Chair in Skullbase Surgery, Alan and Susan Hudson Chair in Neuro-Oncology. He's a world-renowned experienced Skullbase surgeon who is very dedicated towards his patients. He's also an amazing teacher that's always setting good examples, yet a humble human being. We're also grateful to have the distinguished panelists with us today, coming not only from all over Indonesia, but almost all of the continents. I would like to introduce Dr. Rendro Basuki from Sarjito Hospital.
Everybody, nice to see you.
Thank you, Dr. Rendro. Dr. Ari Ibrahim from Kalimantan, East Borneo. I think he's...
Hello, how are you? Hello, how are you?
Hi, Dr. Ari. Thank you for joining us. Dr. Renindra Aman from Universitas Indonesia.
Hello, good evening. Hello, Professor.
Hi.
Thank you. Dr. Dodi Priyambada from Karyadi Hospital, Semarang. I have not seen his account yet. Dr. Julius Julai from Siloam Hospital.
Hi, everybody.
Thank you, Dr. Julius. Dr. Agus Khairul Anap from Comprehensive Brain and Spine Center, Surabaya. Halo, Dr. Acha, terima kasih. Dr. Safrizal Abu Bakar from Pondok Indah Bintaro Hospital, Jakarta.
Hello.
Professor Rida, thank you, Dr. Safrizal. Professor Rida Dharmajaya from North Sumatra. I think he was joining us previously.
Hello.
Okay, thank you. Dr. Ahmad Yana from Tangerang City Hospital.
Hi, everybody.
Hi, Dr. Yana, thank you.
Thank you.
Dr. Yudi Yuwono Wiwoho from Suyoto Hospital, Ministry of Defense, Jakarta.
Hello, everybody. Good evening. Hello, Professor, and all my friends.
Thank you, Dr. Yudi. Dr. Rahadian Indarto from Universitas Airlangga, Surabaya. I have not seen him in the panel. Dr. Irwan Berlian from Universitas Airlangga, Surabaya. I don't think they have connection. Dr. Arwinder Singh from Darmais National Cancer Center, Jakarta.
Hi, hello. Nice to see everybody. Thank you, Selfy.
Thank you, Dr. Arwind. Dr. Doni Wisnuwardana from Universitas Brawijaya, Malang. I don't think he's already connected. Dr. Ryan Rivaldi Keswani from Indonesia National Brain Center.
Hello, everyone.
Hi, everyone.
Hi. And we also have Dr. Claire Karikezi from Rwanda Military Hospital, Rwanda. Hi, Claire.
Hi, everyone.
Hi. Dr. João Paulo Almeida from Cleveland Clinic, Ohio. Hi. Dr. Muhammad Asha from Tawam Hospital, John Hopkins, United Arab Emirates. Hi, Asha.
Hi, everyone.
Thank you for joining us. Dr. Hirokazu Takami from Tokyo University Hospital, Japan.
Yes, good morning and good evening, everybody.
Hi, thank you, Hiro.
Hello, good evening.
Dr. Carlos Velasquez from Hospital Universitario Marqués de Valdecilla, Santander, Spain. I hope I pronounced it.
What's up?
Thank you for the invitation, Selfy.
I hope I pronounced that right, Carlos. And also for the current Skullbase and Neuro-Oncology Fellows in Toronto, Dr. Nilesh Mohan.
Hi, everybody.
Hi, thank you, Nilesh. Dr. Aristotelis Kalivas.
Everybody, hi, Selfie.
Hi, thank you, Ari. Thank you, Ari. Dr. Phil O'Halloran.
Good morning, good afternoon. It's lovely to see everybody.
Thank you, Phil, for joining us. And Dr. Vivek Bodani. I don't think he's here yet, though. Without further ado, I would like to welcome Dr. Gentili for his lecture with the topics, the evolution of skull-based surgery from open to endoscopic approach, current state of the art. Okay. Please share your screen, Dr. Gentili.
Thank you, Selfy.
Okay.
So this will, okay, yes, continue.
Yeah.
And here. And here. Can you see my screen?
Perfect, Dr. Gentili.
Okay. So, Selfy, I just want to thank you and, in fact, your entire Skullbase team. And I see you have Dr. Roland, Dr. Agung, Dr. Guata. You have a Skullbase team, and in the entire neurosurgery group at your hospital for this kind invitation for me to speak at your webinar. It's an honor. We are really in a very, very unique situation, as we all know. This pandemic has really, I think, changed the world order, not only, but around the world. And I think, people keep saying, well, when is it going to come back to normal? I firmly believe there's going to be a new normal. We'll never go back to the old normal. And we have to understand that. We need to, in this time, we need to self-reflect. We need to introspect, look at what really is important to us in our lives. I think this COVID has brought that out. For the first time, we've had time to think about what is really important in our lives. We have to take care of ourselves, not only physically, which is very important. And we as doctors often do not look at after ourselves physically well. We work too hard, we do not eat properly, we do not anything. But equally as important is mental health. And the first time we are understanding that mental health is critical and it's affected, and neurosurgeons, who generally we believe we are supermen. We go into neurosurgery, we are supermen. We are not supermen. We are like other human beings. We have the same problems, same issues. And so we cannot deny our mental health. We have recently a very sad situation. One of our neurosurgeons at the University of Toronto committed suicide because of mental health. It was a sad situation. It's because I think we do not acknowledge. So it's not a weakness, whether you're a resident or a fellow, to admit, to have concerns. So the key is to be very careful and look after our health. Now, I think from every tragedy can come some good. And I think this is I consider the pandemic, COVID, is a real tragedy. Over, I don't know what it is now, 500 million people almost dead, 5 million affected. So it is a tragedy, but what can we come out of it? What positive can we come out of it? Well, I think one of the issues that we've all seen is that, we've learned that we see that the world environment has improved because of our lack of traveling, because of our lack of cars. So maybe we should look at the issue of our environment and maybe relook that, because I think as a global together, we can actually make a difference to our physical world. We've learned also the importance of our family. We've been forced to be with our family, our children, and so forth, and that's become how important those issues are. I think we have to look at the issue of what we're just talking about here. I think this virtual teaching is very important, and I think we'll go continue that in a different way. I remember I traveled to, 15 hours, how many thousands of miles to give a 30-minute lecture. The cost and the footprint and so forth. Why not give these lectures this way, these webinars? So I think that's, something positive. So I think all of these things that, we have to think about, and hopefully, as I said, will come out of this as a better world and a better people. So a little bit of philosophy to start, but this is now my talk. So my talk today is going to be on the basically the evolution of skull-base surgery from open to endoscopic techniques, but look at some of the lessons I've learned and where we basically are currently in terms of the state of the art. Now, many of my fellows, and you've been at meetings, you'll have seen some of these, so it will be repetition, but I always say repetition is good. Learning and so forth, you can never have too much repetition, whether it's anatomy, whether it's a surgical procedure. Okay, so I think if we look at the evolution of skull-base surgery, we have to look at where we've come from. As Carmen Didi said, everything comes from something. Nothing comes from nothing, just like paper comes from trees and glass comes from sand. And I think it's important that we have to know the past. I don't believe we have to live in the past. And you know, mindfulness suggests that you do not live in the past, you don't live in the future, you live in the present. But we have to know about the past to better understand where we are in the present and maybe predict and improve the future. So if you look at open skull-base surgery, and this is important in the issue, it is very similar to any new innovation. There was an initial, this is in the late 60s and early 70s, when skull-base surgery came in, the open skull-base surgery, incredible skepticism. When we first started doing this, people thought we were crazy, doing these kind of crazy procedures, taking heads apart and so forth. So it was skepticism, significant skepticism. And then there was an incredible enthusiasm. We developed incredible procedures and innovative techniques. We were very aggressive. We thought now we can cure everything in the skull base. And but with experience, we found some sober thing that we see that these cause complications. There were limitations. And then in the last decade, we were looking at the outcomes, the quality of life issues, the cost effectiveness and the ethics of these procedures. So the question is, did open skull-base surgery make a difference? Did we make really a difference? And as you see here, these are quotes, and there's a lot of quotes because I'm interested in quotes, that no work is insignificant. All labor, if you try hard enough, you feel you're doing benefits humanity, and dignity and importance should be undertaken with excellence. And even if we sometimes do not succeed, maybe we don't make a difference, but at least we try, and maybe someone else, maybe one of my fellows will make a difference. So the issue is we must try the best we can. But I think there's no question that skull-base surgery, we did make a difference. Before the advent of skull-base surgery, the area of the skull base was really no man's land. No one really wanted to go in that location. The neurosurgeons would come from above and stop at the base. The ENT surgeon would come to the top and stop at the base. So there's no man's land. And skull-base surgery allowed us to transgress these. But the determinants of success in skull-base surgery was really, as is often, was a better understanding of anatomy. And whether Yasser Gill and these people came out, the idea of how important anatomy, surgery is anatomy, 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 anatomy. And of course, the whole issue of magnification, microsurgical technique, the operating microscope, the innovative approaches that I'll show in reconstructions. Of course, improved imaging, anesthetic, perioperative care is critical. We can't do a major procedure without good anesthesia, and intraoperative monitoring and image guidance. But the most important thing about the success of skull-base surgery was the interdisciplinary cooperation and multidisciplinary team. This was critical. It was the first time. Before that, as I said, there was people in little silos. For the first time, skull-base surgery brought specialties, whether it was ENT, head and neck, ophthalmology because of the issues, whether it was plastic surgery, the reconstruction, the free flaps. It was it brought the team together, and this was the first time. Now, of course, everybody's into interdisciplinary things now, but we were the first skull-base surgery of an interdisciplinary team. And this is our skull-base team at the University of Toronto. You can see that basically this, these are, Pat Golaine was my original colleague, ENT surgeon, head and neck surgeon. Dr. Witterick now is the current chairman, but my neurosurgery, but head and neck surgeon, rhinologist, reconstructive surgeons that you can see here, and otologist, of course. But also, as you can see, so many in surgical oncology. We call ourselves basically surgical oncologists because of the tumors that we deal with. But not just that, you know, we made headway because of radiation oncology, advances in medical oncology, the issue of pathology, how important residents and fellows are. Not only, you know, we teach them, but they teach us. We learn from our residents and fellows. And of course, research, we've done a lot of research in skull-base surgery in Toronto. We have a lot of, and that's so important, And so it's funny because I was visiting a special guest at the North American Skull-Base Society. And of course, I said, we were the premier skull-base team in North America. Of course, Jacques Marcos, my good friend, said, no, we are the premier team in North America. So we joke. But the issue is, and I think in Indonesia, what I would say, you know, where you are, you have the ability to, a team is very important, and you should try to have a skull-base team. So did we make a difference? And I said yes. And I think if you look at it, if you look at skull-base malignancies, and these are the issue of squamous cell adenocarcinoma, esthesioneuroblastoma, in the early 60s, you can see the improvement in the survival of skull-base malignancies. And of course, not only surgery, but also, as I said, the radiation issues, but we improved outcome. And for benign tumors, of course, it was even, you know, much more issues. So this is our current, and I update this every little while, but we're over almost 4,000, almost, 500 cases over the last 40 years of skull-base procedures. And this is the procedure we really call true skull-base cases. It wasn't an acoustic neuroma. We did not include the acoustic neuroma or a skull-base, little meningioma. These were tumors that extended through the skull base that you can see here. Esthesioneuroblastomas, and you can see here, these are the tumors we have. So we've done over 4,000 cases. Skull-base surgery, the open skull-base allowed us, and this is really our initial publication of anatomy, a very simple anatomy, as you see, Joe, in terms of the classification. It was really a very simple classification. Region 1 was the anterior skull base and clivus. Region 2 was the anterolateral skull base, and region 3 was the posterior. Very simple. And we then developed many procedures. Some of these were modification of existing procedures. So of course we had subfrontal craniotomies back to the time of Cushing's and these other, but we modified these, as you can see here, through the extended subfrontal, the transvasal approaches, subcranial approaches of Rave. We then developed with our ENT colleagues the mid-face approaches. These are the extended transinfoidal, transmaxillary, lateral rhinotomies were often used. So these were all cases that allowed us basically to access the entire skull base. The anterolateral, of course, was a classical frontotemporal, but then we had the extended orbital-zygomatic, the transmandibular, the facial translocation approaches that we developed. And then finally, the posterolateral approaches, the transpetrosal approaches, the middle fossa approaches, and of course, translabyrinthine. So with all these approaches, there was really no area of the skull base that we could not access. So this patient here, this is a 50-year-old patient that I operated on back in 2003. It's 17 years ago. And before the advent of skull-base surgery, these were difficult tumors. There's no question about it. With skull-base surgical technique, this is a retrosigmoid far lateral transcondylar approach. We're able to access these tumors, and you can see this patient here, I think now is almost 16 years and stable disease. So it allowed us to deal with these tumors that before were very difficult. Likewise, this patient is a young man, as you can see there. I forget how old he was, but in his 30, with proptosis from this basically large anterior skull base meningioma going to the brain. This was a mesenchymal chondrosarcoma. Now, these are very, very aggressive tumors. They're not the low-grade chondrosarcoma, but aggressive. So with a combination, as I say, team approach of induction chemoradiation, at least chemotherapy, then we did the classical, and when you hear craniofacial resection, this was what it was. The bicoronal craniotomy and the combined with the lateral rhinotomy, this gave us access, as you can see, to the entire anterior skull base. We, of course, for the repair, And this young man, as you can see here, now 23 years out, and he's still alive. More important was for these cancers. This is a young man, 29 years of age, presented with diplopia with this ethmoid squamous cell carcinoma. And again, with a craniofacial resection and free tissue transfer, because we have to involve the orbit. If you want to get a cure of these, you have to take the orbit. So we had an orbital exenteration and a free frac reconstruction. Now, ethmoid squamous carcinoma involving the eye had a survival rate like GBMs, basically 5% 5-year survival before these techniques. Here's this patient now, 24 years out, with no evidence of disease recurrence. We offered him a orbital, at least an eye reconstruction, but he didn't want that. He wanted this because I think if you remember, Yul Brynner was a famous actor who had an eye patch, so he wanted to keep the eye patch. So there's no question that the open approach of Skullbase has many advantages. These are traditional approaches. There's no learning curve. These are now become really part of a resident training. At one time they weren't. It was, now they're all part of training. They have advantage that they have 3D microscopic view. They have large working spaces. They're applicable to all sizes, so you don't have to worry about the size or where it is. And we have very well reconstructive techniques with low rates of CSF, and we have long-term follow-up. So what I want to say, ending up with open skull-base surgery, is that open approaches remain very, very important and necessary in skull-base surgery. So any young man, if we have there in our audience that wants to be a skull-base surgeon, he has to know and train in these open approaches, because we still need them and they're still very important. So that's a very key point that I want to make. But what are some of the lessons that I learned from open skull-base surgery? And these are some of the things that I have, that your best teacher is often your last mistake. Some lessons cannot be taught, they simply have to be learned. And the past is where you learn the lesson, the present and future is where you apply that lessons you learn. And ultimately, this is very important, I think. There's no such thing as a failure. You say, I was failure. There are lessons to be learned, but in different ways. So every failure has a positive. So what did we learn? Well, we learned that these skull-base approaches were very maximally invasive procedures. They carried significant risk for complications and the patient's quality of life. If you look at our series that we published in 1999, some of you were not born then, Selfy. I don't know if you were born.
Not yet.
We had a very large group, of the largest series. 50% had some type of complication. Now the 60% are the serious complication, but still. So these procedures, we realized, did carry significant risks. And you can see what they were. The CSF leak rates, the strokes, the pneumocephalus, the meningitis, the seizures. And then we also learned some factors that increase the risk of the neurosurgery polycranial resection. The size of the tumor, of course, the extent, how aggressive we were, dural invasion, the age, prior radiation, prior surgery, the pathology, of course, and the lumbar drain. So this brought us to understand that maximally invasive skull-base approaches should be used selectively and judiciously, and that the least invasive approach that will do the job is the best approach. Okay, so you don't have to be, brag that I do these big approaches. If you have a nice smaller approach that can do the job, you use that approach. It's that's the point from here. And these are studies that were done. You're looking at the working space. So adding on a mandibulotomy, adding on an open sometimes did not increase the working space. So this patient goes back how many years with this very challenging sphenoid meningioma, sphenoid wing. What is the best approach for this? Well, a simple temporal pterional approach was what we did with this. And you can see here, fortunately, the tumor was somewhat soft and that we can get it off the vessels. But here we are after we removed the tumor. Here's the artery. And here's a post-operative MRI scan. So that my point is that basically you don't necessarily have to do these extensive orbital-zygomatic that have increased morbidity, that the majority of cases in these here can be done using the standard approaches, such as this. What is the best approach here? Well, we found out with the endoscopic, at least with the skull-base approaches, that we developed all of these petrosal approaches, anterior petrosal, retrolab, transpetrosal, these here, the Kawase anterior approaches. These are good approaches, but they're significant, require significant training and significant work to these approaches. So to me, when we went, a lot of people, whether it's Sammy, all these people went to these huge approaches, all have come back, the majority, to the simple procedure. And this patient, as you can see here with this tumor, can be done using a very straightforward posterior fossa retrosigmoid craniotomy. Here it is, no added morbidity, 17 years. So my point is just the issue that, look at, the approach and don't necessarily, go and do a very complicated approach with significant side effect when you can do it with a least approach. What other lesson? Well, a very important lesson we learned early on, that long-term follow-up is necessary to obtain accurate data in skull-base surgery. And that it's very important to follow your patients. So now I see, I get to review many papers from journals, and my fellows do very well. They help with the reviews. Many a time they do the review. I don't believe if you see a paper with meningioma with a 5-year follow-up means nothing to me, that paper. Because we know, as we know here with regard to the original Simpsons things, with follow-up, get significant recurrences. So you have to follow up your patients. And in sinonasal cancers, and you can see the survival by region if you follow them. That we found out that the area 2, nobody was alive after 2 years. And this just shows you the thing. This is a patient that I operated on with a chordoma back in 1995. At that point, we're using a lateral rhinotomy. And then next year, we did a far lateral approach to remove with this part. Then we did proton beam. But you can see here, 7 years later, recurrence with a repeat lateral rhinotomy. 3 further recurrence, dead in 2005. So 10 years. So if you don't follow these patients, you say, oh, we did a very good job back in 1995. So it's very important. And this is our results in chordomas. You can see only 60% had progression-free survival at 8 years. And I'll show it later when I do my chordomas. We also learned, this is one of my issues, that technical virtuosity, we all talk about technical brilliance, whether it's the Yassergill. We all want to be a Yassergill. We all want to be these. But cannot overcome tumor biology. It doesn't matter how good you are if you have the modality. So we've learned that these high-grade sarcomas, the SNUC, sinonasal undifferentiated carcinomas, nasopharyngeal carcinoma, neuroendocrine carcinoma, these are not really surgical lesions. And this is a young man that we operated on. He had an infratemporal sarcoma, high-grade sarcoma. We used to do these very extensive radical neck dissections. Here you see I've excised the dura, and all of these patients were dead in 2 years. So we did not do these anymore. We realized that these extensive procedures were not worth it. And now, while surgery still may have some role, it's not the answer for these. So these patients now are treated with usually the chemoradiation protocols and so forth. So it's very important to know that. The other important thing is that surgical excellence cannot overcome anatomical constraints. Again, so for certain lesions of the skull base, whether they're meningiomas, malignancy, following the cavernous sinus, my issue is that surgery is really not the best option for these. And we have to be aware of other treatment modalities, whether it's radiation, hormonal therapy, and so forth. So these are the lessons that I learned from cavernous sinus meningiomas and skull base meningioma. The first thing is, is a Simpson grade 1 removal of a skull base meningioma always possible? Well, I think that's everybody understands that the answer to that is absolutely no. The question is what is the gross total removal rates? I think they're basically less than 30% if you're lucky. I think 50% is actually being generous. And then, so you have to know, so these patients here with edema in the brainstem involving the cavernous sinus, this is an atypical meningioma, as you can see, holo cavernous sinus, carotid encasement. These are not possible to remove by surgery. You should know that from the outset and not even, and try it. So this patient came to me in 1994 with a partial third nerve palsy with this petroclival sort of meningioma. And he came to me and he said, well, can you do it? At that time, we said, okay, I was never a fan of surgery of the cavernous sinus. I'm still not a fan. I think people who do surgery in the cavernous sinus, particularly for meningioma, are a bit, what can I say? But I said to him, we were doing, well, no, I can't do it in the cavernous, but I will take out the component in the, that, you know, affecting the brainstem, although he had no symptoms there. So he asked me, he said, doctor, are you going to help my third nerve palsy, my diplopia? I said, well, no, actually, I'll probably make it worse with the third nerve. So he said, well, is there anything else we can do? And he looked around and he basically went on to have gamma knife radiotherapy. At that time, we didn't have one. He went to Pittsburgh. 25 years later, stable disease. So we come to this thing here that I think is very important for all of you to look at, because it's called the Therapeutic Index in surgical decision-making. That means when you have a decision to make, you should look at these two things. You should look at the probability of tumor-related morbidity. That means if you do not do anything on this patient, what is the tumor going to do to this patient? What is the morbidity? But at the same time, you have to balance that with the probability of treatment-related morbidity. What is the morbidity you're going to cause to this patient? And for me, there's no question in cavernous sinus meningiomas that the pendulum swings heavy over for gamma, at least for radiation. It's an effective therapy, low postoperative morbidity, no mortality, and it's very cost effective. The next very important lessons that I learned was the issue, and now of course everybody talks about quality of life. But the issue is that quality of life is really very important. And sometimes, as you can see, this is from Alexa Carell, that the quality of life maybe is even more important than life itself. And our job, I think, as surgeons, as physicians, is to improve a patient's quality of life, not just delay death. And so there has been, over the last decade, a real paradigm shift in skull-base surgery from that very, very aggressive, at all costs, doesn't matter, you know, that what the patient looked like or whatever, but if you had a good MRI scan and it looked good, that was a success. No, that's not a success. A good MRI scan is not a success. A good patient walking into the office that you've done is, you know, that has good quality of life is a success. So quality of life issues and functional status, we've learned, should be an important determinant of decision-making in skull-base surgery. So when you're doing some of these procedures, you should understand what the effect on quality of life. This brings me up to the issue of complications. And as you can see here, the issue is that some conditions are made worse by treatment. This goes back to almost before Christ, that maybe it's better not to touch. This is the whole issue of when not to operate. And if you think you have seen every complication, this is from myself, you know, my sayings. If you think you've seen every complication possible, you've either been blessed from above or you've not been practicing long enough. Because after 35 years, I still see a complication that I've never seen before. And it's amazing after how many years you still see complications that you've never seen. And then as I note here that the decision to not operate is sometimes more difficult than the decision to operate. So some basic facts I've learned about complications. Complications are inherent in surgical practice, particularly in skull-base surgery. These are difficult procedures, and not all complications are preventable as much as we try. And often, as we all know, we've had this experience. One complication begets another complication in the same patient. Different approaches have different complications. And of course, this is without saying a truism. Complication avoidance and prevention is far preferable and easier than the treatment of a complication. If you can prevent a complication, it's a much better way. Also, be prepared and anticipate complications and report and take ownership. Don't blame your resident, don't blame the fellow that he did it. It's your complication, take ownership of it and report it. Very important to report. And as you know now, there's a thing using Keki Terrell from Mumbai, a whole issue of complications in neurosurgery, and it's a whole issue that's there. And then, of course, as I say here, it's very important not to waste a complication. If you had a complication, learn from that complication. Very important. What are these? Some basic principle of complication avoidance? Of course, proper training. Fellowship, courses, cadaver simulation, mentorships with experienced neurosurgeons are very important. And I tell this to my young people going out. Don't be afraid to ask for help from your senior neurosurgeon. They're there to help you. And if you ask, in fact, they will be more appreciative than if you think you can do everything by yourself the first year you're out and doing things. And then, very important, based on your training and experience, know your own limits at each point of your career. In other words, we all have learning curves. We all have learning. What I did in my first 10 years, I could not do what I did in my second 10 years, and excessive. Just like there's a learning curve in your fellowship, there's a learning curve. So you must know your learning curve. And basically, expertise and judgment results from learning from both good and bad experiences. And then the issue is here, try in the area of evidence-based medicine. We are now in the era. We talk about evidence-based medicine, evidence-based medicine. And we know that in surgery, unfortunately, we don't have a lot of high level in terms of grade 1 randomized, but we should try at least to know as much about, as we can, whether there's evidence-based observational studies, et cetera, et cetera. We should know the literature and have some basis for when we make a decision about something. The other issue is patient selection. This goes with everything, whether you're doing spinal surgery or skull-base surgery. Proper patient selection and engagement of the patient is very important. And that goes back to what I said, when not to operate. And then very critical is you have to have a clear objective and surgical goals. It's like you're going out for a battle if you don't know what the aim is. So when you have a procedure you're going to do, have a plan. Now, it's not always that you can follow that plan and do what you wanted to do, but at least you have to have a plan. See what you are really trying to achieve from the surgery. Are you trying to do a total removal, subtotal, adjuvant? From the beginning, if your decision is you're not going to do a total removal, that makes it easier for you. You understand that your aim is to decompress what is an optic nerves or whatever. And then, of course, select the right surgical approach. The key is to know the limitation of the approach that you're doing by knowing the anatomy, careful preoperative imaging, analysis, and so forth. And then communicate with the team. This is a team approach. You're not the captain of the ship maybe, but you need your sailors to help you because you cannot do things by yourself. So with that, quo vadis, where are we going? And this is a famous quote from Yogi Berra. He was a manager of the New York Yankees baseball team. He said, you got to be very careful if you do not know where you are going, because you may not get there. And then I never think of the future. It comes soon enough. And the empires of the future are the empires of the mind. So this brings us to the inevitability of change and innovation in neurosurgical practice. And those of us who've been practicing for long enough are aware of the inevitability. Change is a law of life. Those who look only to the past or the present are going to miss the future, like John F. Kennedy. Progress is impossible without change. And those who cannot change their mind, and this is very important, if you cannot change your mind, you cannot change anything. And as a surgeon, as you go on, you'll see innovations come in. And if your mind closed, as some of my colleagues that I know for many years still, mind closed, you're never going to change anything. Change is inevitable. Change is constant. Nothing endures but change. Change is the only constant in life. So this is, I think this is a very important quote. This is by Charles Darwin. We all know Charles Darwin of The Origin of the Species. It is not the strongest of the species that survives, not even the most intelligent. This is very important. You can be more intelligent, but it's the one most responsive to change. It's that species that is most responsive to change that will survive. So not even the strongest or the most intelligent. That's very important. So we all are aware of the innovation in neurosurgery, the whole issue of operating microscope, microsurgical techniques, etc. And what I've learned about change is this, very important, that change is a very important, or innovation is an important fundamental part of surgical practice. It's often driven by technology. We know how important it is. We must keep an open mind to change, to innovation and change. Okay, that's if you have a closed mind, you're never going to be able to do it. And it has contributed to important improvement in patient outcomes. But it's very important. Do not be a slave to innovation and change, which can be very costly. So we see things come in that are going to change the world, and they don't. So don't just, for anything. You have to be, because some of them, as you say, can be detrimental. We must assess the surgical innovation, the value of it, and even though it may be complex, we don't have the ability to do randomized studies on site. There's never been a randomized study on endoscopic, in terms of pituitary, as I'll show. So we have to be. This is Scott's parabola of describes innovation and change in a surgical procedure that has not undergone proper things. So we have this very early stage enthusiasm. Everybody thinks this is going to be changing, and you see in the end it doesn't do anything. It falls off the cliff, and it's never used again. So we have to be very careful in terms of looking at the perspective, look at the complication management, and so forth. So this brings us to the next stage of the change innovation in your surgical practice. And in my years of now 30 years, you can see this is all. Now we use this routinely, but at one time these were innovation, intraoperative monitoring. Now we don't do a skull-based case without intraoperative monitoring, without image guidance. The whole issue of endovascular surgery, the radiosurgery, advanced imaging, intraoperative MRI, simulation robotics, and the whole area of minimally invasive surgery began with Neuro-Endoscopy for shunt third ventriculostomy. Now, of course, we have endoscopic spinal surgery, endoscopic pituitary, and that's where we're going to go next in terms of endoscopic skull-based surgery. So if we look at our skull-based approaches now, our experience, we're over about 3,000 cases now. So with the endoscopic approaches, you'll see the majority of these are pituitaries, but I'll show. So endoscopic pituitary surgery really came from endoscopic sinus surgery from our ENT colleagues and rhinologists. And you can see it dates back to the early 90s. And then, of course, Joe and Carrao in Pittsburgh made this, popularized this. And then Capabianca in Naples, Kassam, of course, had to do it. And this is, I put our thing here because we did the first publication of a largest series of endoscopic in 2008. I'll just go over that. So what are the advantages of this innovation of endoscopic approaches to the sella? Well, the whole issue is the improved, excellent wider view, limited field of suprasellar, parasellar structures, closer view of the surgical target, better delineation, no retraction. Some of these are basically question marks I put there, you see, because the issue of less invasive, some people would say, well, yes, it may be less invasive to the brain and things, but it's more invasive to the nasal sinuses. So, but the whole issue, we're still trying to determine these cost effectiveness, better outcomes, and so forth. There are disadvantages to the endoscopic approach, all shown here. The issue of they require training. There's a learning curve, instrumentation, and is very important. So this is basically a pituitary that we did. This is with the old speculum, hardy speculum that she hears. So the difference with the endoscopic approach was like seeing another, when I first did this, seeing basically like another world. This is us trying to drill in there. You can see it virtually gone. Look at the issue with the endoscopic approach. The carotid prominence, lateral carotid recess. You can see here the planum, the tuberculum. It was really, it gave us a view that we had never seen before. And so, and I'm just going to very quickly, so don't waste a lot of your time. Here we are after the removal, the medial wall of cavernous sinus over here, and then going back to the endoscope, at least microscope, you can see the difference in the visualization. And this is larger tumor. Again, showing the ability, the beautiful view that you get with the endoscope with the pituitary tumor. And again, just to show you here, the medial wall of the cavernous sinus, which were very difficult to see before. Here's this, the diaphragma coming down. We can go posteriorly and also anteriorly, that we're taking this off. For the first time, it allowed us to see. We did not do any blind dissection. And here we are here all the way here very quickly. And this is after the removal. And this is what you want to see, basically. This is a post-operative MRI scan, nice removal of the tumor, 12 years, no evidence of disease recurrence. This large tumor here that is a giant pituitary, which initially probably might require a craniotomy because it's very difficult to get this anterior part via, it's transsphenoidal. Now, with our ability to basically do a transplantar approach, it allowed us to now remove this tumor here. And then again, I'm just not going to waste your time with all of that. This is the cellular part of the tumor. And then here's the planar component that we removed. And then it allowed us to go basically anterior to the tumor. And here we are. This is after the removal of the anterior part. Here we are with the optic nerve. And this is after the removal. You can see the optic nerve, the A1s shown up here, the pituitary stalk, of course, which did not work. This is the patient post-op, as you can see here, 9 years without any evidence of recurrence. So this is my evolution, as you can see. In 2003, I started doing it. Actually, my first case was in 1997, when I had to do it through an intraoperative MRI that did not allow microscopes. I did my first case there, but then subsequently we continued. So over 4 years total, went over to the endoscopic approach, and I haven't done since 2007, as you can see here. So we've done now over 2,000 almost pituitary adenomas, and there's no question that to me the endoscopic approach is a procedure of choice for pituitary adenomas. This is our series. Very quickly, we had very, very high rates of gross total removal rates if there was no invasion of the cavernous sinus. But once you had cavernous sinus invasion, didn't matter whether you use endoscopic, whatever. It's very difficult. But we were obviously able to decompress the optic apparatus, and this was our results. We looked at the average weighted of the microscopic series, and our present series we got actually better results, as you can see here. But again, very important, very low median follow-up. So we have to be careful. And now we're trying to look at long-term follow-ups that we've done. Our group has looked at this for long-term follow-ups. And this is just another series. I'm going to go quickly here on recurrent. After having a microscopic, we then did a endoscopic approach. We see that very good rates, high rates of gross total removal rates in the non-functioning, 86%, Cushing, 75%. These were better results than they had before when you had to do a recurrent a microscopic approach. And then giant adenomas are a real challenge. And we published also this, it's in 2014, just to show you a case of a giant adenoma here that the endoscopic approach allows. Really, this is a tumor that you can see here going up to almost the third ventricle. And we basically, these are, I won't go because of the time, but we all do middle turbinectomies in our endoscopic approaches for pituitary. Then we, in a case like this, particularly always a nasal septal flap, particularly the giant ones that there is a high risk of CSF leak. And then we do a very wide sphenoidotomy that you can see here. And then the removal is basically done the same way. And then some of these, the giant ones are more difficult. You can do an extracapsular removal. Many times you can't. And then here's a diaphragma that's come down as we're taking it off, and you get a nice removal. You know you've done a nice decompression of the ish. And here's a nasal septal flap. Just let's go back to here. There's a nasal septal flap, and then over here. And this patient showing here 1 day post-op, nice removal, 1 year post-op, improvement in the vision. These are our results. However, in giant, you can see that the results, and one of the things that I see, I think people presentation. It's very important to present results. It's my philosophy and so forth. If you do not present results, you can present 10 beautiful videos of whatever, but you have to in the end present your results. So even with the endoscopic approach, you can see in giant adenomas, they're still challenging. We felt we got a gross removal in only a quarter of the patient, 25%, 24%, near total about 41%. So these are still very challenging lesions, despite our new techniques. In any case, there's no question for pituitary that it is the current state of the art, and I believe it will become the standard of care for pituitary surgery in the future. Now, evolution of endoscopic skull-base surgery. It came, as I showed you there before, it came from endoscopic pituitary surgery. to expanded approaches. And it really is interesting now, because as you see, this is the same slide I used for the very my first slide when we talked about open skull-base surgery. And it's interesting that the endoscopic skull-base surgery went through the same stages, and people forget when they were, looking at, saying about endoscopic, that the open skull-base, we went through the same phases: initial introduction and skepticism. People thinking you're crazy taking these, skull-base tumors through the nose, resistance, significant resistance, then, innovative techniques, again, that enthusiasm, and then the sober idea of complication, the CSF leaks. And where we are now in endoscopic skull-base surgery are really looking at trying to determine what are the true indications for skull-base surgery. What are the limitations? Do we have any data on outcomes and results? So I think all we can say now, up to 18, that the early results for a variety of pathology in selected patients are promising, but we lack long-term outcome. And I talked about the importance of the long-term outcomes. So the advantages of endoscopic approach, of course, all the similar advantages that I told you with pituitary. For these are, some of these lesions that you can see here, cranial meningiomas, are much more direct approach. No minimal brain retraction, avoids craniotomy. You get this beautiful panoramic view that allows us to access these sites. But we cannot deny some of the disadvantages. The issue of, these are technically challenged doing these tumors through the nose. There's a decreased working space and instrument manipulation. Complication management is not as easy. If you get a vascular injury using an open approach, put 2 temporary clips, get a 9-0 suture and suture it, cannot do that with an endoscopic. You get a vascular support and you got to take that vessel. So, and then the whole issue of reconstruction and CSF leak, and then the whole issue of a learning curve. You cannot do these procedure if you go to one course and then go back and take out a tuberculum cellular meningioma. It doesn't work that way. You need to do a full training, and there's a learning curve. These are the prerequisite for success in endoscopic skull-base surgery. Anatomy, anatomy, anatomy. It's a different anatomies I'll show you, but it's still anatomy. We need this interdisciplinary team of surgeons. And for my pituitaries, Selfy and those other my fellows know that I don't use ENT sometimes, but generally not. And I think, it's not necessary. I think the nasal anatomy, you can learn. But for the expanded approaches, I always use, and it's very important that for these expanded approaches, transcribiform approaches, transpterygoid approaches, it's important to have a good ENT and rhinologist. You need, of course, the bimanual binostril technique. We are microsurgeons. We are two-handed animals, and we cannot do anything, with one hand. Of course, instrumentation is critical, and then I showed you the learning curve. These are the different. These are the Pittsburgh group looking at the different transcribiform, transplanum, transclival, transcellular, and then there's a coronal plane where we look at the issue of the transpterygoid approaches. This is actually from my fellow, I think, Joel. This is from your partner Roland collection, but also looking at the different approaches, the anatomy of the approaches. So this is, you're looking at transnasal approaches, transcribiform, transplanum, transcellular, transclival approaches. And this is just, it's a different view. This is for the transcellular, transtubercular, transplanum approach. We're looking at the same anatomy. Here's a nice dissection from Joe looking at the sella tuberculum planum, carotid. Here we are from the above view. Same anatomy, but a different view. Look at transcribiform approach, and then also here. So these are the approaches, and these are the potential indications. These are all, again, from the Pittsburgh group. We've modified those, but, transcribiform, of course, aesthesia, olfactory, nasal sinus tumors, for the transcellular, transtubercular, the transrectal meningioma, the craniopharyngioma, etc. The transclaval, of course, the most common one is the choroidomas. Some people do meningiomas. I'm not a keen fan of that. And then these other ones. So this is one of the cases that brought us to do these expanded approaches. This is a patient that one of my colleagues, Mark Bernstein, sent to me, that my fellows all know Mark, a very good surgeon. He had operated on this patient twice before for a dermoid. This is a dermoid, and then it recurred. This is a third time. And he also presented with a pituitary. So he said, Fred, he's referred this is, but can you deal with this at the same time? And, we had just started doing these expanded approach. And I said, yeah, I think, we'll look at that. And so this is what we do basically is here's a transcellular approach. And this is basically drilling down the planum and the tuberculum. And again, I won't waste your time doing that. First of all, we took out the transcellular tumor, the lesion, and now we're taking off the component transtubercular. Here we are. We're opening the dura, and you can see the typical. This is a dermoid, typical hair that you can see. And it allowed us to get a nice removal. Of course, there's no way that you can get a total removal of this in terms of the capsule after 2 operations and so forth. We had a nice removal. Here's the patients 4 years later, no evidence of disease recurrence. So this then brought us to the issue of being able to do some of these. So here's now our current total, about 500 cases of expanded endonasal approaches to Skullbase. And here's the pathologies. Okay, craniophryngiomas, chordomas, aesthesia, these are the same pathologies almost as the open approaches and others. The paranasal sinus lesions were. What I'm going to do now, very quickly, hopefully, go through and tell you where I think the endoscopic approach now has the role to play, a major role, where there's, I think, very little role, and some, are some role. So let's look at benign extradural lesions. These are paranasal sinus extradural lesions. So what are these types? Encephaloceles, CSF leaks, juvenile angiofibromas that you can see here, schwannomas, meningiomas, solitary fibrous tumor, inverted papilloma, cholesterol granuloma of the petrous apex. And the indication is yes, these tumors now can in fact be done all using a pure endoscopic approach. You do not need open approaches for this. And you can see here, basically, this is a anterior fossa encephalocele, middle fossa encephalocele, cholesterol granuloma of the petrous apex. I have not done a CSF repair now, an anterior scalpel repair open for about 10 years. It's not necessary. These can all be done using a pure endoscopic approach. And here's the cholesterol granuloma, the clavicle just medial to the carotid that's coming here. You can see where the carotid is, just lateral to that. And then juvenile angiofibroma is shown here. It can be removed strictly by transmaxillary and endonasal approach. This is a capillary hemangioma and a hemangiopericytoma that we had. First of all, of course, this was embolized. This can all be done using a pure endoscopic approach. No need for a craniofacial resection at all. And in fact, any lesion in the paranasal sinuses from the anterior frontal bone to the clivus, like this biopsy-proven meningioma. This is a meningioma of the paranasal sinus. This is coming out of the maxillary sinus that you can see here. The only way that you can get it out, and this is this patient done purely using an endoscopic approach, no open approach. And here we are after the removal of the tumor. You can see the periclival carotids here. Here's a sella, and here's the sella here. So no CSF leak, length of stay 3 days, 7 years. This patient remains stable. Now, there is as I said, the expanded endonasal at least a coronal plane. And these are not used as much, but occasionally are. And what I've used these for is here's a V3 schwannoma of the temporal fossa that can be done using a transpterygoid approach, a combination of transpterygoid and transmaxillary approach. This is an epidermoid of Meckel's cave that we did here that is can be done using an endoscopic approach, using a transpterygoid. Here we are. There we are. So this is the carotid artery. So we're lateral basically to the carotid arteries, paracellular carotid arteries. And then this is after the removal. You can see here the temporal fossa over here. And then the other issue is orbital lesions. Orbital lesions that are medial to the optic nerve can be removed using a pure endoscopic approach. Any lesion lateral or superior, then we use an open transcranial approach. What about malignant lesions? As you can see here, we have about 50 patients now. The most common is an esthesioneuroblastoma, such as this, these small lesions like this. The endoscopic approach really has a definite indication. However, very important, patient selection here is critical. You have to pick the patients properly. So here's a small lesion. What we do basically is an anterior skull base resection from below. And what we do is it's very important here to be able to get free margins. These are oncological procedures basically, and you have to maintain oncological procedures. So in this case, in this patient, doing a transcriptiform, we were able to get free margins. In this patient, you can see no CSF leak, 5 days, 4 years later, he remains without disease recurrence. There's a larger lesion, as you can see here, going intracranially. Biopsy anesthesio. This patient, we do pre-op radiation. What approach? Well, to me, again, the endoscopic approach is a good approach. This is after radiation. That's why it looks like that. So we go here and ultimately do an anterior. I'm not going to waste your time. Here we are. The key here is to get these are the anterior and posterior ethmoidal vessels. They supply basically vessels, and then you basically do an anterior craniofacial, and then you remove the dura that you can see here. And then here we are removing the dura again. Let me just go very quickly. And then we're taking off the falx because it comes down, and we've got a gross total removal here. And again, the important thing is to get, and here's the olfactory nerves that we have to excise. These are done with a combination of always fascial lata, biological, and of course, these patients do not have the nasal septal plaque because of the tumor in the paranasal sinus. This patient, you can see post-operative course, no CSF leak, length of stay 5 days, 10 years, no evidence of disease recurrence. However, there are limitations. Because these are cancers, as you can see here, this patient goes intracranially, but it goes lateral over the orbit. And there's no way you can get a free margin with an endoscopic approach this way. So this patient, we did a combined. And there's nothing wrong, with combining. And I think Professor Goto yesterday had a nice thing where he did a combined open and endoscopic for cranial. But so this was done combined using endoscopic plus open. You can see here, you can see from above where we did the suturing of the dura, and you can get a nice removal with a combination. So in conclusion, with regard to sinonasal cancer, evidence in the literature now supports that endoscopic resection is very feasible and good in, however, very well selected patients. The surgical principle of oncological resection, it means gross total removal with negative margins, must be preserved, and we have to understand the limitation of the endoscopic resection. And you can see here, this is just from the endoscopic versus the craniofacial resection, really similar outcomes. What about chordomas? Chordomas, the answer to me is, first of all, a little bit of the anatomy. This again from my fellow Joe did a very nice dissection of the transclival approach. You can see here what we're looking at here, clival carotids, and the key is to get lateral and inferior down onto the inferior sella, and this is showing you beautiful anatomy, showing here the basilar artery and periclival and paracellar. So this is really what's called an clival. This is an extended endoscopic transclival approach for these chordomas, the majority of them, and just shown here. The open approaches we used to do, of course, with the bicoronal approaches, the many posterolateral transpetrosal approaches, anterior orbital-zygomatic approach, because these tumors can be quite extensive. So I looked at, what are the results of 25 years of open approaches for chordomas? What were we able to do in 25 years? So as you can see here, I showed this before. This patient in 1995, lateral rhinotomy, far lateral proton beam, 3 recurrences, dead in 10 years. This is our series, at least not our series. This is a SEER database, populated of 400 cases of chordomas. You can see that the median survival was 6.9 years, but the 5-year survival, as you can see here, was 67, 10-year 39, 20-year only 13% of patients with chordomas are alive. So while the literature supports that the degree of resection improves survival, I'm not sure that the open approaches we've done very well with the open approaches. So this is the issue with regard to my conclusion that despite the current best effort, overall results in chordoma remain disappointing with open approaches. We need new strategy. And the question, of course, is, does the endoscopic approach offer advantages in the surgical treatment of chordomas? And can endoscopic techniques reduce complications, or are we dealing with tumor biology and that chordoma is not a surgically curable disease? That's an important question. So the advantage of chordomas are the same advantages that I showed you with the other. These are midline lesions, so these are midline approaches. So I'm not going to bore you again because of the time, but here's an upper clival chordoma, extradural. These are very nice. These are just, you might as well be doing a pituitary tumor. Mid-clival chordomas, you can see here with intradural extension, and holoclival that you can see here. This is a lower clivus. So this can all of these can be done using an endoscopic approach. And the interesting is that, you know, people don't understand, always think that these are extradural. At least in my series, at least a third or more of these have intradural extensions of these chordomas. I'm just going to show this one video of this patient, 44-year-old, with this large chordoma going into the brainstem. Has a 6-nerve palsy, very classical for a chordoma presentation. What is the best surgical option? Open endoscopic. Well, to me now, there's no question the endoscopic approach is the procedure of choice. And this is the anatomy that I showed you. This is what we're basically going to do. And here we are now. So you see, he had a type 2 sphenoid sella. So we had to drill down this entire bone. You know, it makes it easier if you got it fully pneumatized. So here you have to be careful going laterally in terms of using image guidance, so forth. And here's where it went intradurally. You can see superiorly, and here where it went intradurally. And now we're basically going to take open the dura, and then this is you can see the tumor. This is was quite stringy, and it was attached to the vessels. So very careful, bimanual microsurgical technique. You can do the same thing that you did that you do under the microscope. And this is after the removal. Stop here, and over here is after the removal. Let me take that over. So we see this is skeletonization of the basilar artery, the perimedian arteries, the tumor that went into the brainstem. This is the patient's postoperative MRI. You can see got a nice removal, re-expansion of the brainstem, and post-op shown here. This patient underwent IMRT radiation. We no longer send patients for proton beam. At least our results suggest that IMRT photon radiation has the same results basically as proton beam. And I'm going to very quickly then. This is one to show you that generally for chordomas, the approach is generally for a midline lesion, but occasionally you can get, if you get a nice soft lesion such as this. This is a chordoma that goes laterally, as you can see, over basically to the CP angle, to the trigeminal nerve. You can see the fifth nerve over here. So very quickly, I'm going to go. I have time to show you the entire, but that if you get a nice soft tumor, here we are, going lateral, really using also a little bit of a approach. Here we are. There's the Vidian nerve and Vidian artery, and then taking down here we are. We're taking it out. Here's a basilar artery going out laterally. You can see, and this is not using a 0. This is using a 0-degree endoscope. Fifth nerve, you can see here, 7th and 8th nerve, and sometimes you can do the removal of these soft tumors even from that. Here's the postoperative MRI scan showing here. Okay. So there are limitations to the endoscopic approach. Lateral, posterolateral extension beyond the petroclival segment is an issue, and this case here that goes quite far lateral in the brainstem to me is not a good approach for simple endoscopic. So this one we do combined. We do a combined open approach, which is a transtentorial subtemporal approach to take care of the tumor in the brainstem lateral. And then, of course, the midline approach is very simple for endoscopic approach. In this patient, you can see. Just show these studies, and the answer is basically, have endoscopic techniques? I think the answer is yes. While the series are still small and short follow-up, I think that we have level C and D evidence that the endoscopic has proven to be a viable alternative to transcranial procedure. And I think with proper patient selection, the more direct and less invasive nature, I think the endoscopic approach is really the approach of choice. And that, however, a well-trained skull-based surgeon needs to be familiar with both the endoscopic and open approaches. Craniopharyngiomas, very briefly, with craniopharyngioma, you had a nice talk yesterday. I just want to go quickly to show you some of the controversies in craniopharyngioma. These are difficult tumors. As I said yesterday, it doesn't matter that these are difficult tumors. They remain very challenging, and that the overall management remains controversial, whether to do it. So these are controversies that I see in craniopharyngioma. What is the best approach? Open endoscopic? What is the best surgical strategy? Should you try to get a radical removal in every case, or subtotal removal and radiation? And then this is my own caveat. Is it possible to remove a craniopharyngioma totally? I'm talking about totally, every microscopic cell, and spare pituitary function in the stalk. I have my own views of that. And the management of recurrent craniopharyngioma, which is really a very difficult problem. So very quickly, what is the best approach? Well, you can see where I've gone. Over the last decade, from 2008 to 2018, I've gone way over from the open to the endoscopic approach, almost 5-to-1. For primary lesion, 13-2, recurrent lesions, so almost 5-to-1. So why? Why is this? Well, because of this. And it was shown yesterday. 76-year-old gentleman with his craniopharyngioma. When we, back, we would have done this using open approach. And this was done initially using open approach. So what approach? Open. Well, there's many approaches. Pterional approach, you can do a subfrontal approach, you can do an interhemispheric approach, supraorbital approach, microsupraorbital approach. The problem with all of these approaches are good approaches, but the limitation to these retrochiasmal component of the tumor. Here you see we don't even have a optic carotid thing. We'd have to go prechiasmatic or lamina terminalis, and they're very difficult. And there's retraction injury to the brain. So this patient was initially tried through an open approach, did not really have any significant removal. And then this is the endoscopic approach in the same patient. You can see it's like a different world. You can see us taking this off the medial wall of the hypothalamus and use the third ventricle. We are taking it off the optic chiasm, but because of the open approaches, we have to leave some there. Now, this patient was, I think, 67. So the aim was not to get every microscopic cell on the lateral walls. We can see here, and this patient, that you can see, we left some tumor in the lateral wall, at least the hypothalamus, medial wall of hypothalamus. But this patient did very well, improved his vision. He was pan-hypopit and had no CSF leak. So there's no question to me that the endoscopic approach, as was noted yesterday, really has significant advantage for craniopharyngioma, and I've virtually gone over to the endoscopic approach. Again, I don't have time for anatomy. Here's one, a solid cystic component. This virtually blind. This patient had finger counting in one eye, 2,800 in the other eye. What approach? Again, no question in my mind that the best approach for this is the endoscopic approach. Again, you saw this yesterday. I'm not going to hear. The key in this approach that allows you is the sparing of the superior hypophyseal vessel to the chiasm. And this is where sometimes the open approaches, the vision is worse. You get worse vision. It's because of the vascular nature of these. That the endoscopic approach allows us this beautiful view of this. And here's this patient, and these are true. This is not him. From finger counting back to 2020, 6 years, no evidence of disease recurrence. And I can go and I don't have time to show you the different sizes of tumors shown here. Now, is it possible to remove craniopharyngioma totally and spare all pituitary function? My initial philosophy was that no, you can't. That the embryology of this tumor arises from the stalk, and so the ability to remove it totally and spare the stalk to me would be very difficult. But then with the endoscopic approach, we had some better view. I said, well, maybe this is possible. And here's a tumor, a very nice tumor, small tumor, you can see here, and using a transplantar approach. And you can see here, everyone would love this kind of tumor. Not calcified like Dr. Yoda showed yesterday, these calcified difficult. Here we are taking it off nicely over the chiasm, sparing all the vessels. The pituitary stalk, you can see, is on this side. So this is exophytic to the right side. So as we come out, we're taking this off nicely, and let's just take this off. And here's after the removal. Look at that. We spared the stalk, and so my view was that post-op, here it is, sparing the stalk up here, and post-op, the patient had transient VI, but normal pituitary function. So I said, I must have been wrong that now with the endoscopic approach, we can remove a total tumor and spare things. We can cure craniopharyngiomas. Correct? No. 3 years later, and a half, 3 years later, you see recurrence, cystic recurrence. And where did it recur? Right in the region of the stalk. So there were cells left in the stalk, microscopic cells that do it. So I must say that, and then what we did, of course, we went in and did a full hypophysectomy and removed the tumor after the post surgery. So I must say that for me, at least in my experience, and you can never say in medicine never or always, but I think it's rarely, if ever possible, to remove a craniopharyngioma totally and spare all pituitary function. This is very important. I think the issue of what is the best surgical strategy? Should we do radical removal in every tumor, or what about subtotal resection radiation therapy? And you can see, okay, what did here. If you look at the issue of total removal of craniopharyngioma, this is all the way back 1990 from Yastergill, you see that the complications are very high. He's an excellent surgeon, the pediatric. DI in 86%, permanent replacement therapy in 87%, postoperative obesity, 50% of pediatric cases, severe obesity in 40%. And this is from Marie Chou, a very good French pediatric neurosurgeon, that even in recurrences, even after so-called radical removal, recurrence rates were up to almost 40% in recent series. So this brought, and then as you see in terms of cognitive and social functioning in children, after removal, significant issues, and particularly also in adults. So this has brought a pendulum swing in the surgical management of craniopharyngioma over the last decade, from a total resection to attempt to get a cure, but at the cost of endocrine, hypothalamic function, poor quality of life, to a more conservative multi-therapy modality, where the aim is to deal with the problem. If it's vision, deal with the vision. If it's functional preservation, improve quality of life. And so the issue is, well, if you do that, what about higher recurrences and radiation side effect? Well, the pediatric literature suggests that's not the case. This is the results of the treatment of craniopharyngiomas in the literature, looking at progression-free survival and overall survival with subtotal removal and radiation and gross total removal, and there's really no change. You have to keep this in mind. You cannot ignore these. And we've now seen in similar data in adults, and we have to take into consideration when we're making decision making. So this is a 63-year-old gentleman, visual dysfunction, normal endocrine. And I told the patient, I can take this all out, but you're going to be pan-hypopit, you're going to be on thyroid, DDAVP, so on. Or I say I can do remove out, improve your visual function, but I will likely have to leave a little bit. But you may have a recurrence, but we can deal with that with radiation. And he said he did not want to be taking pills. Whatever you do, I don't care, just deal with my vision. So basically that's what we did. We did, I'm not going to show the movie. You can see we left some right at the pituitary stalk, exactly where, the edge was. So what do? We watched that. We observed that, 2014, he had disease progression. You can see there, it became increased. He had radiation, 2016, and you can look at here now, 2018, less. So it has, it can come down. So now 4 years post-op radiation, he's very stable and things. So I don't think we can ignore the issue. And if you look at the long-term results of fractionated radiation therapy in patients with craniopharyngioma, we see that very good results. Long-term control rates, local control rates, 95% at 5 years, at 10 years, at 20 years. And so I think we have to look at this, and that there are excellent long-term results in patients with craniopharyngioma after stereotactic radiosurgery with low treatment side effects. However, there are limitations. And here, what about this? Well, this, I think some people might want to do it endoscopically. To me, they went too far laterally. So I did this using basically an intrahemispheric transcallosal approach. We did a nice removal, as you can see here, but I did leave a little bit right at the very, very end. And I followed this patient 1 year post-op, cystic recurrence. Then, of course, I did an endoscopic approach shown here. And then as we did a transcellular approach and the third ventriculostomy from below. This is our series, and unfortunately I'm running very late, but that we just published in February 2019 on recurrent, at least in suprasellar meningiomas. You can see here very briefly that our results, 44% gross total removal rates, but we had 50% already were recurrent cases. In the primary lesion, we had a 73% gross total removal rates, but when the objective, because in some older people, the objective was not to get a gross total removal, it was 81%. Very, very satisfying visual outcomes of 95% stable improvement. Follow-up mortality 0, 21% CSF leak rates, but with our lumbar nasal septal flap, we are now to less than 10%, 6 or 7%. So in conclusion, with craniopharyngiomas, I think that the management remains a significant surgical challenge. I consider it a chronic disease. Quality of life matters. What about future trends in craniopharyngiomas? This is just a case that we've had recently. We know now that there are BRAF mutations in papillary craniopharyngioma. This is a patient that I had back in 2010. She was operated elsewhere, visual dysfunction. Then in 2011 had radiation. 2015 had repeat cranie. Then they referred her to me, and I did an endoscopic approach in 2019, but she had residual disease. So then we sent her to our neuro-oncologist, looking at the groin. What do we do now? Repeat surgery again after 4 surgery, open endoscopic medical therapy. This patient was papillary BRAF mutation. This is we did targeted therapy with dapirifenib and tarmidine, and here's this patient now 6 months later. Look at the shrinkage of this just dramatic. So we cannot again ignore that. So management of craniopharyngioma, I think, needs a multidisciplinary team, surgery, chemotherapy, and radiation. Finally, the last one is meningioma, and this is probably the most controversial area in skull-based surgery, particularly endoscopic. And to me, it's good to have controversy. I said it's good. It stimulates discussions, drives progress. What is not useful is dogma. When someone says you must never do this, you must always do that. And in anterior skull-based meningioma, there is a lot of dogma. There are those that say you must never do this. Yes, sometimes. So why all the controversy and why? And this goes back. This controversy is not new. As you can see here, Harvey Cushing, back in the 1916, he also looked at the issue of what is the best surgical approach. Even then, they were talking about that. So there are nice open approaches for anterior skull-based meningiomas, the bilateral approaches, the unilateral approaches. As I showed you, these have significant advantages, but there are some concerns with the open approaches. And these were multiple approaches for, not one approach. Again, the whole issue that I told you before, but these are not even as important as the recognized complication rates. And if you look at the open approach, the series, up to 30% in terms of some visual disturbance in open approaches for anterior skull-based meningioma, tuberculum cell meningioma. So again, the question that I asked before for cranial, can the endoscopic approach address these shortcomings and of the open approaches provide us with equivalent or better data? The advantage is shown again here. I'm not going to go over this, but we have to keep in mind that, for the anterior skull-based meningiomas, it really applies to only very few. If you look at, if you do away with all of these others, it's only olfactory groove, suprasellar meningioma are the only basically ones that really it applies. So can this be done endoscopically? The answer is yes. This is done using a transcranial approach. That's the way we did it. And this patient is 5 years off. You can see, not an issue. Nasal flap reconstruction, OR 7 hours, probably more than it would have been with an open approach, no CSF leak, but the patient did have loss of smell. So this one is a larger tumor. Can this be done? The answer again is yes. Let's say 5 days, postoperative MRI scan shown here. Can this be done endoscopically? This patient is a physician, smaller lesion. She was offered many approaches, and she wanted basically an endoscopic approach. She did not want to have training. And here's a very, very quick, I'm not going to show you here, this is the tumor as we're taking it off. Now there's the optic nerve and the tumor, and after the removal, there we are. Nice removal. That's a small tumor, and there we are. Repair a nasal septal flap. Here's this patient's 7 years, 2 years, 7 years. And then I'm not, again, don't have time. If we look at here, this is 1 year, 4 years. This is 5 years, 6 years. This is 7 years, 10 years after an endoscopic approach. Should this be done endoscopically? Can this be done endoscopically? The answer obviously is no. These are all the contraindication for the endoscopic approaches. You can see here, lateral extension, vascular encasement, a significant hyperostosis. So this to me is definitely not an indication for endoscopic approach. And this was done using an open transbasal interhemispheric approach. So you can see very nice approach. What about this patient? Can this be done endoscopically? I think the answer is yes, but should it be done endoscopically? And to me, no. Because this patient, you can see it encases the carotid here, and to me, and a little bit into the canal. So to me, I would not do this endoscopically, and I did this basically because of optic canal invasion, lateral extension, carotid encasement. So I did this using a pterional approach, drill down the clinoid, get a nice removal, as you can see here. So this is not a good case for endoscopic approach. What about this one? Now, 44 years of age, has normal smell. Can this be done endoscopically? The answer is yes. Should it be done endoscopically? 10 years ago, I would have said yes. Now I say no. Why? Normal smell. So an endoscopic approach for this procedure will cause loss of olfaction. You cannot spare olfaction. So this patient, has normal smell. So I did this endoscopically. I just open. You can see here, I do these bifrontal interhemispheric. We were able to spare one olfactory nerve. You cannot not always spare olfactory nerve, even with an open approach, but you have a better chance than an endoscopic approach. So these are the favorable indications, and these are the unfavorable indications: large size, significant lateral expansion. So just very to quickly go through, what is the value add now in terms of, you say there's only a few cases, why should you be doing any endoscopic? Is it less brain retraction? Is it better visual outcomes? Well, in terms of, visual outcomes, you can see this patient is a 58 years old. And there's no question with the open approaches, there's always an element of retraction on the you see it's very, as much as you're careful but to get this from underneath the optic nerve, it's not that easy. And there's always a bit of retraction of the optic nerve, and these are very vulnerable nerves. And that's why the issue of, the decrease of vision in some series. So if we look at this, and I'm just going to show you can do a very nice removal, ultimately, and postoperative vision improve, no neurological deficit, and here it is. But look at the difference between that and this patient here with an endoscopic approach. And again, just very quickly take you here. Okay. So in this situation, the difference that you can see is we do not touch the optic nerve, basically. Over here, and here we are, we're taking it off. And look at these very, very critical vessels to the optic chiasm that we spare. You can see this patient had a significant compression of the optic nerve. Yeah, look at that there. The optic nerve was almost eroded through from the pressure. And so if you had any manipulation of that nerve or any of these vessels, you would be a problem. In this patient, you can see a significant improvement in his vision, left eye, so 5 years. If we look at the literature, we see that in terms of the visual improvement, there's better visual improvement generally in the endoscopic approach. But we have to be careful when we're comparing, as is shown here, in terms of apple and oranges, because some series will put olfactory groove with planum, tuberculum. As we know, these are all different types of tumors. So this is from the group looking at similar cases that could be done, a similar cohort. So these felt could be done either open or endoscopic. And if you look at, the improvement in vision, significantly better vision. Some people disagree that, these were so bad, but that's the reality from their series. CSF leak, of course, there's increased CSF leak, but like anything, even in the open approaches, we started at 30% CSF leak, and now we're getting these down to an acceptable level. And this is our own series. This is from Bernath in World Neurosurgery, which was published in 2018, looking at 10-year experience, because we wanted to look at the long term. Again, when I say it's so important. So we looked at olfactory groove. We did 6 endoscopic, 13 open. tuberculum, 13 open, and 20 endoscopic. And this is our overall gross removal rates, as you see, 77% in the open and 69% in the endoscopic, slightly higher in the open. CSF leak rates were, I don't think they were significant. And the tumor recurrence were again a little higher in the endoscopic, but not significant. So what were our recommendations? We were asked to do these papers for the first international consensus statement on endoscopic skull-base surgery. This is using evidence-based review with recommendations, or the protocol, the UNEC protocol. And this looks at the level of evidence and the grade of recommendation. And we did olfactory group meningiomas, and this is our conclusions, basically, that really case selection bias was really very difficult to compare open and endoscopic. And in spite of the increasing experience in endoscopic, the extent of resection is still inferior to the transcranial with higher leaks of CSF leak rates. So currently there's no hard data showing the superiority of the endoscope technique over the open approaches. So if you do this open for the olfactory group, you keep doing it open. For those of us that, we have someone that can, olfactory smell is gone, it's a nice little lesion, I want to do it endoscopically, I can do it. Similar with tuberculum meningiomas. Here, basically, with careful patient selection, the endoscopic approach can result in equivalent gross removal rates as open approaches with better visual outcomes. And again, we're looking at evidence C and grade of recommendation 4. So where are we in endoscopic skull-base surgery or parabola? Has it gone into the other side, falling off the cliff? Well, I don't think so. I think we are here basically, we're looking at carefully selected patients that I think there's a definite role to play. And here's my final conclusion. The endoscopic is now an accepted alternative to open transcranial procedures. Appropriate training, a team approach are important prerequisite, has a significant role to play in benign extradural paranasal sinus lesions, and will replace and has replaced open approaches. The endoscopic approach has an important role to play in overall management of primary and recurrent craniopharyngioma, can achieve results comparable or better to the bust microscopic series. Of course, meningioma remains very controversial, as I said, but in experienced hands with careful patient selection can result in comparable gross removal rates and recurrent rates as open approaches. So where are we going? Some people would suggest, open versus. I think we're beyond the open and versus. We are now basically there's a need for both open and minimally invasive endoscopic surgeons. So the skull-based surgeon of the future is going to be basically a hybrid surgeon. And I'm going to quit there, Selfy. I have maybe a next webinar because I wanted to look at the issue of the training of the skull-based surgeons of the future, but I'll do that at another time.
Okay.
Thank you for your attention.
Thank you very much, Dr. Gentili. Thank you for your excellent lecture. It really is enhancing our understanding, both the practical and philosophical aspect in the evolution of skull-based surgery, and reminding the importance of multimodality treatment in skull-based surgery. I'm sure that many of the participants would love to see your amazing operative videos, Dr. Gentili. Maybe we should do another 3-day course after the pandemic, like a real one, not the virtual one. But I think for now, thank you for that. And for now, I would like to invite the question and comments from the panelists. And maybe the first one, Professor Goto, if you have any question or comments. Professor Goto is the professor and chairman from Osaka University. Thank you very much for joining us tonight. Please.
Thank you, Professor Gentili. Nice presentation about the skull-based surgery. I completely agree that your final conclusion. Open and endoscopic surgery is very important for the skull-based surgery. As you said, we all skull-based surgeons have to learn the endoscope and microscopic technique to select the suitable approach to the patient. So I thoroughly enjoyed today's lecture. Thank you, Professor Gentili.
Thank you, Dr. Goto.
Please unmute Dr. Selfy.
Selfy, you're muted.
Thank you, Dr. Gentili. So for the panelists, if there's any question or comments, if you don't mind, just raise your hand or just press the raise hand button. Maybe I would like to invite from Dr. Renindra. Please, Dr. Renindra.
Thank you, Professor. Very nice philosophical aspect of the skull-based surgery and the evolution of the endoscope and the microscope approaches. And now that you have concluded that it's a combination between microscope and endoscopic approaches that we have to deal the lesions in the skull-based surgery. Just one short question that in recent years, as you know, there have been a development of exoscope. So microscope, endoscope, and exoscope. So what is your opinion about the exoscope tool? Will there be a place, or will it have a experience of evolution also, like the endoscope? Thank you.
Thank you. That's a good question. And I must say, I have not had experience with the exoscope, so I'm talking without experience, and that's not good. I always say to people, before you can say something is bad, you must try it. That's why my skull-based surgeons that I had that didn't want to do endoscopic because they never did it. So I said, you must. So I've not had any experience, but the people that I've talked to that have had it do not see a significant advantage to the exoscope. I mean, it's versus a microscope. The issue is, if you're going to do something open, then do it under the microscope, where you can have 3D vision and so forth. So that was my understanding from them. They were not totally impressed with the exoscope, but I've not tried it, so I have to, before I can say anything, I have to try it.
Thank you, Dr. Gentili.
Okay.
Thank you. Thank you.
Thank you, Dr. Nanda. And I saw that Professor Rida already raised his hand. Please, Professor Rida.
Yes, thank you. Excellent presentation. I think it's hard to hear something from somebody who already have so many years experience like you, Professor Gentili. It's an honor to be here to share an experience from you. But I want to ask is about do the sterilization with what kind of antiseptics or aseptic agents that you do in for sterilization during this kind of pandemics, because nowadays we still receive some patient that after now the government said we are in a new normal, and the patient is now coming, and we try to plan to make an elective operation. And so with this kind of operation, usually adenoma hypophyseal, like the things that we used to use the transnasal endoscopic transsphenoid approach. Thank you.
Yes, I think as I was mentioning yesterday, obviously transnasal procedures for people who are, potentially infective is a bad, they have the highest viral load is in the nose. And so, we test all our patients before the surgery. So they have to have, negative swabs. They're not, but still, despite that, we act as if they are positive. In other words, we act, so we use a N95 mask. We use a face shield for endoscopic. When we go under the microscope, you have to take off the face shield. But the gowning and the offing and doffing is all done, in a very protected way. We are generally not there when they intubate. The anesthesia, you stay, outside and you go in after that. So it's the issue of being very, very careful, being protective during the surgery, but we do operate on patients. We have patients going blind with apoplexy. We have no choice. We have to operate. So the key is just being very, very careful with protective, with PPEs.
Mm-hmm. For especially
fortunately, so far we have not seen any positive staff in terms of developing COVID. Even our ENT surgeons who do operate up through the nose all the time, doing nasal issue, they have not, we've not had any evidence of positive, doctors.
Okay, thank you.
Okay, thank you very much, Professor Rida. And next, I think Carlos is raising hand. Please, Carlos.
Yes, thank you, Selfy. That was an excellent presentation, Dr. Gentili. Many thanks. I was looking forward, though, to hear your ideas about training and the future of training in endoscopic. And I was really interested in that. I understand that the time is probably not enough, but probably you could briefly comment about that, because I think it's difficult these days to overcome the learning curve for a young trainee or a young consultant. And as you said, we are doing endoscopic approaches for selected cases. So we don't have a lot of cases to overcome that training curve. So what can we do in that matter?
Yeah. So I think, Carlos, it is difficult, and that's why my final conclusions were, John, if you are doing only pituitaries and only occasional pituitaries, not hundreds or 200, then to me, then the extended approaches are not that useful to you, because to do these extended approaches, you have to be doing them frequently. So that's why people say, well, why are you doing this, tuberculum cell meningioma, small one, endoscopically? I say, because I'm in there every day, either doing anesthesia here, doing many pituitary every week, as you know, when you were with us. So now I have a little cherry that's just chipping up. And why would I not get that cherry? But someone who has not been doing it, and suddenly, they maybe do a pituitary here and there, and then now they see this and they want to do that. No, that is stupid. You're used to doing it, and now we know with regard to the open approaches, you can do a super eyebrow. People are doing, super eyebrow for these, or terional, classical. So don't make it hard for yourself. It's a question of what is your experience, what is your daily work load in terms of endoscopic cases. And that really determines, when I talked about the issue of know your learning curve. And for some of you may never get to that learning curve of doing endoscopic anterior skull-base meningiomas. I'm doing a webinar next week in Mumbai with, I'm talking about endoscopic approaches for anterior skull-base meningioma, and Henry Schroeder, as you know, the other, and he's very against, even though he did endoscopic, originally he came, and now he's gone totally out of it back to open approaches. And so, the issue is that I don't say to anybody, you should do it. I mean, if people say, no, you have to do it. No, you do what you're comfortable with, what you do most, that you are. And so these endoscopic approaches are difficult approaches, and they should be done only by people who are doing them commonly, frequently. And that's my opinion. Don't feel bad, because people feel bad. Oh, I'm doing this the old traditional way. I'm not in the most advanced. People are doing endoscopically. No, don't feel bad. You do a good procedure using a traditional approach with a good outcome to the patient.
See, I always come to your class and tell you, oh, let me listen.
That's to me a success beyond measure.
Thank you, Dr. Gentili, for your reply.
Thank you very much, Dr. Gentili. Thank you, Carlos. And for next, we have Dr. Shafrizal. Please unmute yourself.
Okay, thank you, Dr. Selfy. Very great presentation and nice discussion, Professor Gentili. I want to ask you some questions. According to your experience, what is the most difficult complication during your endoscopic approach, and how to handle it? And the second question is, what's your opinion about the transorbital approach? Thank you.
So in terms of complication, as you know, the most dreaded one is a carotid injury. Now, touch wood, I have to touch wood. I've never had a carotid injury. So to me, I'm worried because, you know, if you never had it, sometimes you're going to have it. But I'm very careful with regard to the carotid. If there's any question that, whatever. So, but the carotid injury, of course, would be the most dreaded thing that you must immediately coagulate this, and immediately after you packed, go to INR. They must, do an angiogram, see that if there's an annular infiltration, deal with it using endovascular techniques to occlude the vessel. Now, but I've not had that. To me, CSF leak remains a concern in endoscopic surgery, particularly in expanded endoscopic surgery. And for those people who suggest we've solved the CSF leak rate in endoscopic, the answer is no. We have not solved it. They still have, and every time I do an endoscopic approach, an expanded endoscopic approach for a cranial, that I'm still worried about CSF leak. So that's the one that I'm most concerned about. And we've developed now a protocol based on other people, and that what we do is the key for these are, first of all, multi-layer closure with biological material. So fascia lata, I take fat. The nasal septal flap, when you can use it, it's also very useful. And then very important to mobilize these patients early. Our standard procedure was keep them low, keep them in bed, keep them flat in bed. And that's actually not good. You're keeping in bed, the CSF pressure is actually higher when you're supine, down, whatever. So we mobilize them very rapidly. We get them walking within 48 hours, 20 or 48 hours. We keep them up at 15 to 30 degrees. They nurse them that way because you want low pressure, in the brain. So together with the multi-layer closure, the nasal septal flap, together with the early mobilization, that is, that we use to prevent CSF leak.
Okay, what is about the transorbital approach?
Now, transorbital, you mean endoscopic?
Yes.
Endoscopic. Yeah, I don't know if you saw my talk. Maybe you didn't come on, but I showed you that, yes, there's a role for the endoscopic, and we've done, I think, maybe 3 or 4, not too many, for intraorbital lesions medial to the optic nerve. They have to be medial to the optic nerve. Can be done using basically an endoscopic approach, transorbital medial approach. And so we've done cavernomas, hemangioma, I was going to say, of the orbit. But any lesion that's really larger, lateral, superior, I do an open approach with removal of the orbital roof and lateral wall. But the small lesions, medial, yes, the endoscopic approach is definitely feasible. And we've written, there's an article in the literature showing that we use a nasal septal flap as a repair for the medial wall of the orbit when we do that procedure.
Okay, thank you so much, Prof. Gentili.
Thank you, Dr. Shafrizal. So next, Dr. Acha, please unmute yourself.
Okay, thank you, Selfy. Professor, thank you very much for your nice presentation. I would like to ask about what do you think about the supraorbital eyebrow approach for anterior scalpis tumor, like tuberculum, meningium, olfactory groove, clinoid, and planum. And the second question is, when professor do the endoscopic surgery, when do you do it alone or join with ENT surgeon? What kind of case? Thank you.
Okay, good. So I say, as I said before, I believe, and people swear by the supraorbital approach. I do not do that approach. I am the classical. I trained with Yazergil, so I will do like many perional approaches, and I believe that those are good approaches. And if you can, become facile with those, you become expertise. I believe that they're good approaches. But I myself do not do those approaches. I use a standard perional or mini perional. But people, say, and they have very good experience with the mini perional. To me, has always been the issue of exposure, and I cannot understand with such a small exposure how you do not it's necessary to retract some brain. That's all but to me, I cannot say it's a bad approach. It's how you're trained in it, and if you can do it, you should definitely do it. The other question was what was the other question?
About when do the endoscopic surgery, Professor, when do you do it alone or?
Oh yeah, yes, that's very important. I think from the point of view of the pituitary, standard pituitary, I think, when you start, if you want to have ENT, because it'll show you the nasal anatomy and how to, to do that, fine. But in the end, I do not use ENT for straightforward pituitary. I think the anatomy is pretty straightforward in terms of doing it. So I do not use it, but for all my extended procedures, all my, crenopharyngiomas, chordomas, anterior skull base, I think it's important, very important, to transpterygoid approaches, to M.Kes cave. I use my ENT colleagues, rhinologists, and so forth. So I think that's very important to have, as I said from the beginning, to get a good team, get someone that you can trust, and that will help you with these expanded approaches.
Okay. Okay. Thank you. Thank you, Professor.
Thank you, Dr. Acha. And next, we have Dr. Endro Basuki. Please, Dr. Endro Basuki, unmute yourself.
Okay, thank you, Professor Gentili, for your nice and very important presentation about the history of skull-base surgery, open endoscopic, and the aim is the quality of life. I agree very much. My question is, you do the transnasal hypodysectomy for the functional adenoma or non-functional adenoma. How is about if the adenoma is not clear, circumscribed, or not, or poorly demarcated tumor? Do you need to check histopathologically during the operation?
So, Selfy, just to if you could just repeat that, was the issue whether we do intraoperative quick sections for pituitaries?
Yes, yes.
Yeah.
To make sure that clear already.
Yeah. So we do not do any intraoperative pathological analysis of pituitary because our pituitary pathologists refuse. They say they cannot do the studies on the adenoma to be able to tell us and so forth. So we do not do that. Sometimes it would be nice for Cushing's, to see, because you do not know whether you got the disease to it. But we do not. They do not accept any quick section for pituitary. Particularly, some of these are so small. The Cushing adenoma, they don't want to use it for quick section. They want to do it for the molecular profiling and so forth. So no intraoperative pathology for pituitaries.
Okay, thank you very much, Professor.
Okay.
Yeah.
Thank you, Dr. Endro. And next we have Dr. Claire Karekezi. Please unmute yourself.
Hello, can you hear me?
Yes, clearly.
Yeah. Yes. It's a pleasure seeing you again, Dr. Gentili, and thanks a lot for this wonderful talk. I am always interested in your philosophy about training, teaching, and it has been an honor and a pleasure training with you. So I wanted to ask you, what do you think changed within your first years as an attending, and the other first 10 years, and the other first 10 years that followed those years, like in terms of learning curve, how did you improve your endoscopy techniques, And what would you give as an advice for a young neurosurgeon who is starting doing endoscopy? Should we keep attending cadaver courses? How do we keep improving our learning curve?
Yeah, Claire, those are very important questions. Are not easy questions to answer. You know, the issue is, I think, goes back to the issue of having an open mind. So you say, you know, why did I go to endoscopic? I was I was one of the founding members of the North American Skullbase Society, Open Approaches. I was there. So why then do I go endoscopic? And I was 50 years old when I started, endoscopy. Is the issue, first of all, to keep an open mind. That was, I said, as part of my thing there. Keep an open mind. You see something coming in, you look at it, and then you say, hey, this doesn't sound right to me, but I must try it, or I must go see it. Must see go to a course or something to see it. Then the issue was when you decide, and of course, as I said, for endoscopy, I think you really need a fellowship, as you've done, to do it, to see a course and then go back, maybe for pituitaries, okay, but anything else more extensive, I think you need a fellowship training. And then to not be worried that you did your fellowship with me, you go back and you say, I want to do now everything Dr. Gentili did. Well, you're not going to do everything Dr. Gentili did. That takes time. So you start basically with small cases, good cases. Don't try to do the difficult cases, because your early cases will determine your own self assurance and also your colleagues' assurance. They see that you'd have bad complications in the early cases, they stick with you from forever. So just, start with the more easier cases, and then do more of those. And it's like anything, neurosurgery is like any other profession, whether carpentry. The more you do, the more facile you get. So in terms of, in pituitary surgery, it took me, 40, 50 cases before I became comfortable with the idea that I can now do this and go expand it a little bit more. The other thing is, as I said before, don't hesitate to ask for help from your senior colleagues, other people that do it. It's not a sign of weakness. It's not a sign of thing. You're starting out, you want to learn, and your colleagues, senior colleagues, will be much more appreciative. You ask them, then you got this young person going there, thinks he can do everything, without it. So ask. Yes, I think you should continue to go to courses, because things change, and refresh your course. Once a year or something. We have many good endoscopic courses available. I teach, at the AirCAD course and other courses in Brescia and so forth. Very good courses. So keep on top of that. See if there's anything new things that have developed and so forth. Keep learning. We never stop learning. If you think now I know everything I need to know, I stop learning, you already you've already failed. So keep learning. Keep doing as you do more cases, and your learning curve is such that it'll come. Sometimes slower than others, depending on your situation. Whether you're in your country, whether it's another country in Asia, whether it's Indonesia, whether it's wherever, there's a situation. And I always tell my fellows, remember, I think I told you the idea to not become impatient, because the first thing you want to do when you go back is that exactly what you were doing in Toronto. Well, it's not going to be possible in many places, but you start early, you have patience, and slowly, and it may take years. So the key is that to me is the critical points.
Thank you.
Okay, thank you very much, Dr. Gentili, for the very important advice. And next, I would like to invite Dr. Julius. Please unmute yourself, Dr. Julius.
Thank you, Selfy. Thank you, Professor Gentili. I always enjoy all your talk. Very honest, comprehensive, and all the philosophical advice. I think I am very true. I very agree with all what you mentioned. Even for myself, after I learn it from you, I have now over 700 endoscopic pituitary case. I still don't feel comfortable for expanded approach yet. Only very, very few.
The microphone, please. The microphone, Dr. Julius.
Dr. Julius.
Hello.
Okay, yeah, you're good.
Can you hear me?
Yes.
Hello. Hello.
Yes.
Hello.
Oh. Yeah, now we can hear you. No, no.
Okay, now we can hear you, I think.
I'm sorry, I'm sorry. So my question is that for young patients with pituitary tumors that we see for over 5 years that no recurrence, but after that they have recurrence, how can we justify when we introduce radiations for them? Whether straight after the second surgery, after the recidive that we find. Thank you.
So that is a good question that we're looking at now to determine when is the indication to consider radiation in pituitaries. And I have series where I've operated on 1, 2, 3, 4, and so should we do it after the first one? So to me it relates a little bit to the anatomy. Where the recurrence is. If you see something in the cavernous sinus, as I told you, you're never going to remove the tumor totally from the cavernous sinus. So if you have, a tumor that you remove, a big tumor, you did a nice job with the decompression of the optic nerve, but you see significant residual tumor in the cavernous sinus, you have two options. One, if you are able to, in our country, we can follow patients very carefully, right? So I see every 6 months, I see the first sign of recurrence, bang, radiation. Sometimes in their countries, and I don't know if your country where you patients you lose them. You cannot follow them up, and then becomes the issue of maybe should you consider radiation for that? That's a situational thing, as you see. It's not easy. So I do not do upfront, but I will look at where it is, watch it carefully, and if it's in a location that I know that I cannot get a total removal by surgery, and a repeat endoscopic, I will consider radiation for pituitaries. Now, how many times did you say? 3 times, depends where it is. If you see a recurrence or something, you can get at it with an endoscopic again. It hasn't gone to cavernous sinus, and I would consider a repeat endoscopic case second time. But the third time, now I'm getting to the point. If I haven't been able to achieve a good removal in 2 times, I'm not going to do it the third time. And in pituitaries, of course, pathology becomes very important. You have to look at the pathology, and the silent corticotroph adenomas, the subtype adenoma that are aggressive with MIBs very high, 9%. Those are the ones I'm much more aggressive with radiation.
Okay, thank you.
Thank you very much, Dr. Julius. And next, I would like to invite Dr. Irwan Barlian for the question or comments. Please unmute yourself.
Thank you, Dr. Selfy. Thank you, Professor Gentili. Very nice presentation. It inspired me. I have some question. First is I want to know about your opinion about. I have to start the skull-base operation. So many times I feel that this sometimes it is too much. So after we decompress the cistern, so I think the opening is very big. So, and of course the exposure is enough, but I think sometimes it's too much for the opening. And then we try to make it simple, make it smaller, and then it's not enough. So what is your opinion about that? And the second time is about the cosmetic issue. So sometimes we operate and then the result is good, but patient always come to us complaining about the cosmetic sometimes. So I'd like to ask you about how is your opinion to explain to the patient about that. Thank you.
So I'm not quite sure. Is this with the endoscopic approach or open approach?
Open approach.
Open approach.
Okay, so yeah, to me, I think exposure is very important. And then, as I say, I do a standard, terional or mini terional. To me, that gives you the exposure that I need. So the mini eyebrow approaches, it may be very good, minimally less invasive, but to me, it means probably a little bit more retraction of the brain and so forth. So I use a standard approach, the terional approach, that gives me a very good exposure of the entire anterolateral, the Sylvian fissure splitting. You can see the entire, there. Cosmetic relates to what you mean. To me, I've seen, not because I don't do it, that the eyebrow approach can be cosmetically not so good. The terional, of course, is behind the hairline, so there's no scar. But the mini eyebrow approach can have a scar. As far as cosmetic results with the terional, particularly if you're drilling down the sphenoid ridge significantly down, I will do a titanium cranioplasty. There, I put a titanium cranioplasty that prevents that hollow of the temporal area.
Okay, thank you.
Thank you, Dr. Ib.
So you close the skull base with titanium.
I put a titanium thing to where the sphenoid wing has been drilled down, because I drilled down the sphenoid wing right basically and really far anteriorly to the orbital meningeal branch that goes there. So that is going to be a defect. So I put a titanium mesh that the muscle goes over, so that it prevents that defect on the temple.
Okay. Yes, thank you, Professor.
Thank you, Dr. Ibi. So for next, I would like to invite Dr. Muhammad Asha to give a question or comments. Would you mind unmute yourself, Dr. Asha? Thank you.
Thank you very much, Selfy. Dr. Gentili, it's a great pleasure again to listen to you, and it brings back very beautiful memories about being with you in OR in Toronto. I would like to ask about the expanded endoscopic cases and whether it's good to do that too much in the beginning and then scale it down, or stick to the sort of bare minimum required. If you remember, I've discussed with you a case of mine of tuberculum meningioma, and I couldn't sleep for days thinking whether I should put a lumbar drain or not. And you kindly helped me with that dilemma, and we ended up not putting a lumbar drain. Things went very well. But I wonder if it's better to do take several steps of precaution when you are starting, and then start to scale it down with time, or have a system from the beginning and build on it. So move up rather than move down. What do you think?
So my view is, the latter, to start slowly and then build up. The issue of the lumbar drain was very simple to me. It went back to, again, looking at the literature. We used lumbar drain initially, and I don't know if you saw my talk at the very beginning, the determinants of complication. A lumbar drain was a determinant of a complication. Adding a lumbar drain added pneumocephalus, dental pneumocephalus, whatever. So we stopped using lumbar drain in the open procedures. And so similar, in the endoscopic was the same issue, that, you put a lumbar drain, and if you've got a CSF leak, you're going to get, more air up there than you are. So that's where that came in. So it has to do with experience, has to do with learning. So for sure, I think you cannot, because it goes back to my initial thing that I think I told Claire, that if you go really strong, get problems when, with the major procedures, you're going to have trouble getting back. So start slow. Once you've done many pituitaries, then you can go on that, the endoscope. You can go lateral, again, with an END colleague, a transpterygoid approach to do it. So to me, it's always been a building block, basically.
Thank you very much.
Thank you, Mo. And next, I would like to invite Dr. Almeida. KP, you can unmute yourself.
Hello, yeah, okay.
Hi, Dr. Gentili. Congratulations on the presentation. Very, very nice talk this morning. And my question for you.
I see that you have, Joe, I see you have Toronto behind you, so you cannot get Toronto out of your
yeah, CN Tower, Lakefront.
You cannot get Toronto out of your mind, can you?
yeah. I have a small lake right next to me, but nothing compared to that one. So my question, I actually have 2 questions for you, and they're more like on the personal side of things. So the first one is really, well, you, as you showed, like you have a gigantic experience. As we know, you started on the 80s with the Skullbase approaches, the open approaches. And then you were, at least in my point of view, one of the few ones that decided to embrace the change and incorporate endoscopic Skullbase approaches into your practice. So that to me at least shows that you were at that point very open-minded and you saw the future that approach could have. So I'd like to hear from you first. What do you think made you, first of all, to realize, oh, this is something that I should, try and consider doing this? And what do you think were, at that point, the personal characteristics that you had that helped you to realize and to embrace that change? And the second question for you is, I was very fortunate to have the chance to work with you and Selfy and all the other fellows in Toronto, and it was a beautiful experience. And there's one thing that we all agree on is that you are one of the really excellent points of the Toronto experience. Everybody really enjoys working with you because you're very honest, you're very open to questions and discussions, and you always try to engage with us and give us this type of professional advices that you're giving. So in that sense as well, on your background, personal story, what do you think helped you to understand those differences in people and to help you to understand how important it is for other people to have somebody like you to engage? Because I'm sure you realize that we all appreciate not only your technical strategies, but also this personal and philosophical feedback you always give us.
So Joel, the first question is an important one, and the issue was with regard to the endoscopic. As I said in my thing, do not be a slave to any new that came in. So to me, what made me go into endoscopic? Because you have to have problems with existing techniques, right? If you have a perfect technique that gives you perfect results, why are you looking for something else? The problem was that we did not have a premier. I would do a pituitary, a microscopic pituitary. I'd look at the postoperative scan and I said to my residents, I said, no, this is not the patient I operated on. Because the tumor would be left laterally and as if it was, I had a problem with the technique, the microscopic technique, as nice as it was, and Hardy brought in that, it was even better than before, but still there was a problem with it. So you have to, first of all, have a problem with something. If you don't have a problem with a technique, you do well, you get good results, stick with it. Don't, go because somebody else is doing something there, if you do it. So that's the first thing. There was a problem with regard to the microscopic approach for pituitaries. You did not see well, as I showed you there outside. Second of all is that issue, as you said, that I have, a philosophy that I have. I cannot say something is not good or stupid or whatever without me trying it. So when the endoscopic came in, I know I had a problem with the microscopic pituitary, and then we did the and then I'd say I don't give even myself that great credit of saying it, because we had an intraoperative MRI, the original one, that 0.5 Tesla, and then we were going to do a pituitary because I saw I had problem. I wanted to know now we could see it after, and they said no, you can't use a microscope because of the magnetic thing. So I asked Dr. Witterick to help me with that first one, and I saw the wide view. It was amazing, to the point that I couldn't tell, because it was at that point it was like flat. I went up into the cribriform. I couldn't see what the cella was because the cella looked flat. So I went up and we got a CSF lead from there. But the side story. But the view was like, as I showed you there in that craniopharyngioma, it was like a different view. So then based on the fact that I had a problem, based on the fact that now I saw this, then I went and took a course at Pittsburgh with Joe. What's his name?
Hasan.
No.
Joe.
Yeah, Joe. Yeah. So I did, and then I saw that and came back, and then gradually, and then because there were not fellowships there, I did it myself, slowly with the microscope always at the ready in case I needed it, until gradually you cut the umbilical cord, and then no more. So it's, I think that's the issue here, that if you see something new, first of all, you have to keep an open mind, but you have to have a reason to do something new. It's not just because it's new. It's a fad, so everybody's into fads, and that's what they always said. Oh, you're into fad. But no, I said it adds certain things that I can't add the others. So that's the issue. With regard to, as you know now, mentorship is critical, I think. And we all have mentors. We all have mentors, non-medical mentors, other things. So the key is, I think you should search out mentors, and wherever you are in terms of, that's what I meant before about asking your senior colleagues. Don't be afraid to ask them. And so I think I cannot stress the importance of mentorship, and you'll have them, as you go through your life, and then you become a mentor to others. So, and then in terms of personality, you say, well, why? I don't know. This is people's personality. We all know personality. You run in your life. You've run through people with excellent technical skills, amazing thing, and then the personality is not so quite what you would expect. So this is something that I don't know. You learn that. Is it genetic? Is it something that's in your personality? I can't speak for others. This is how I was brought up. It's we're all our products of our upbringing, our parents, our family, where we were born and so forth, and that you can never make up that in other ways.
Thank you.
Thank you, Dr. Almeida. And next, Dr. Arwinder Singh. Please unmute yourself. Thank you.
Thank you, Dr. Selfy. Excellent presentation, Professor Gentili. I would like to ask only one question. In one of your slides, for this huge sinonasal tumors, pre-op radiation therapy was given. In which types of tumors do you consider giving pre-op radiation, and did this affect your resection? Was it more difficult or was it more easy after pre-op radiation? Thank you.
So that's a very good question. And Toronto is a little unique. As you know, I mean, as neurosurgeons, we generally resect and radiate brain tumors, whatever. In the University of Toronto, for whatever reason, 20, 30 years ago, the radiation oncologist, and the main reason, the main pathology, by the way, is esthesio, the classical one, the esthesioneuroblastoma, that most centers around the world will do the surgery and then they radiate. The Toronto group, they radiate first in surgery. And as a neurosurgeon, I was not totally happy. I said that. First of all, I said, radiation is one of the issue that I found in complications. So we have to operate now after radiation, the healing, and so forth. But the arguments of the radiation is that they, with the tumor there, they know where the tumor is and can do their dose planning and so forth and whatever, and it's much more feasible. To do it post-operative, they do not know where it is. They have air, whatever, and they said whatever. So to them, for their ability to do the radiate, they feel it's better for them to do it pre-op, and that's a real main reason that pre-op is really radiation oncology argument. And they do it also for squamous cell carcinoma and adenocarcinoma. And it depends also on the extent. We've had some that are, with a radiation, they can shrink it down significantly with regard to make surgery even, better. So it may be a little bit of a unique situation, but in Toronto, we do the pre-op radiation for specifically esthesios and some adenocarcinomas and squamous cell carcinomas.
Right. And how long will you do the surgery after the radiation? I mean,
about 4 to 5 weeks. 4 to 5 weeks after the end of radiation, they feel that there's there's enough that we can then do the. And I must say, if we look at our results and I can't say there's been significantly more complications before because we do the pre-op radiation.
Right.
In terms of healing and infections and things like that.
Thank you, Professor.
Thank you, Dr. Arwinder Singh. Next, Dr. Dodi Priyambada. Please unmute yourself.
Thank you, and a nice presentation and nice lecture and philosophy. It is inspiring me. Professor Gentili, I want to ask about instrumentation. Do you need a specific, you use specific instrumentation for doing surgery, extended endonasal surgery like this? I mean, if you doing surgery with a scope 30 degree, you need a 30 degree bipolar or something like that. Please tell me. Thank you.
Yeah, I think instrumentation is important. As I mentioned before, I believe still we do not have very, very good instrumentation even from the companies. And fortunately, we do not absolutely need it. Now the Storts, they have a special long bipolar that allows for intracranial, but the ENT bipolars that they have are enough for me to do most of definitely all of the pituitaries and some of the others. But instrumentation is important. We need scissors that are not bayoneted scissors, that are straight scissors. So to a degree, I think it's important, and the companies do have sets for endoscopic approach, and I would look at have your hospital look at the companies, look at the things that are that are available. But to answer your question, is still I think they could do better with regard to the instrumentation for the endoscopic.
What your recommendation? Do you have any recommendation instrumentation, Professor?
No, in terms of, I think many companies, depending what your hospital looks at, we use generally Storts because we started that way. So the Storts instrumentation for endoscopic, they're good instruments, and we use generally there, and we use the nasal instruments that our rhinologists use for the access part.
Thank you, Professor.
Thank you, Dr. Dodi. And next we have a question from our current fellow in Neuro-Oncology, Dr. Aristotelis Kalivas. Please unmute yourself, Ari.
Thank you, Selfy. Thank you, Professor, for the great talk. Training with you is an honor and a pleasure. And, I spent some time in Edinburgh, and I got into this whiskey thing. So, and I said from a neurosurgical perspective, your teaching and is like a very good single malt because you have a mature whiskey, and you can sense the flavors, and you have a single malt and a blended whiskey, and because you are so sincere with your approaches, your experience, your complications, you get a very good, mature, single malt neurosurgical opinion from you. So to that aspect, you said you touched upon the issue of, we're training with you, we're doing so many things, expanded approaches, difficult approaches, and then we go back to our home hospitals, and we have to, from one point, we have to maintain our skills and even get even better. And from the other point, parallel to that, I think we have to work on how we're going to create a referral pattern, a practice to be able to operate on these tumors. And to that aspect, what are your tips for people that they go back to other countries? Because Toronto has a very, very nice system, organization, referral pattern, big institutions. So what are your suggestions for people that go back to other countries? What can they do to create this referral pattern to be able to operate on this tumors like that?
Yeah. So, as I think mentioned before, it's difficult. Different countries have different issues. So, one size does not fit all. Whether it's Greece, Spain, whether it's Africa, whatever. So that you have to understand that there's individual issues. But to me, the first thing is to get a good collaborator. Find a young ENT person who's just come on like you, they're interested, and try to get, collaboration so that, you start that. And then you have to let people know what you're doing. So each of you, whether you're there may be little things that you can talk at a little symposium around. Go and talk to the general practitioners if they have little things to say. Come back, you're doing these kind of things, and that you're ready and happy to do these. Let them know what you're doing. Give rounds, to the hospital. Give what you did. Show what you did during your fellowship. And so I think the issue is exposure, collaboration. Is the start of doing that. And start, as I said, don't start with the worst case possible. Start slow, get good results, and just slowly. And unfortunately, Ari, patience. You have to have patience. It's not going to happen like that. It's going to take time. It takes maybe years to then get back to where you wanted to do. You wanted to do that as soon as you came back. You may not be able to do that for a few years.
Thank you.
Okay. Thank you, Ari. And next we have Dr. Yudi Wonowoho. Please unmute yourself, Dr. Yudi. Thank you.
Thank you, Dr. Selfy. And thank you, Professor Gentili. I would like to ask Professor about your opinion that long time ago, my professor, when I was in a medical studies student, he said that the big surgeon make a big incision, and then it's changed to the big with the sentence big surgeon is make a small incision, and the white surgeon knows when he or she must stop the surgery. And what's your opinion, Professor Gentili, for about that? Is there any some philosophical opinion from you? Thank you.
Yeah. Well, I think you've summarized exactly what I said in my speech. The most difficult thing for a surgeon is to know when not to operate. To say, as much as our lives are to operate, that's what we do. That's how we do it. But there's sometimes we cannot help the patient. So don't operate just because you think, you have to. So the key, that decision, I think it is very difficult. And do not be afraid, do not be ashamed to say, oh, well, I'm a failure. No, some things, as I showed you there, some lesions, some conditions are such that surgery is not the right thing for them. So to come to, how do you learn that? Time, experience, lessons learned. You'll learn lessons because you tried one, it didn't work, So I think, that's important to understand when you cannot help the patient. And if you have that as a primary goal, I think that's very important. You don't look at the MRI scan. which is fine. You see that big tumor, but what are you trying to do? How can you help this patient? How can you help this patient? If he's going blind in one eye, you should be able to help that vision, but not removing that all necessarily and causing major complications. So to me, I think that is very important. And the other thing that you say about large, and again, in part of my talk, I said that to me, the most smallest incision, or at least the least invasive approach that will do the job is the best. So the big approaches that we use, we're not using those anymore. They're not necessary. It doesn't make you better because you use a bigger incision. Use the incision based on your experience that will do the job. If that incision is a small incision, if sometimes you do need a large incision. I'm doing a meningioma that is huge that I'm going to be doing that needs a big incision. I can't help that. But use the incision that's necessary to do the job, not because it's big or small.
Thank you, Professor.
So your professor was very wise even then. Yes.
Yes, he was. Yes, he was.
Thank you, Dr. Thank you, Dr. Yudi. And thank you, Dr. Yudi. And next, I think we are running out of time. I would like to remind all the participants to fill in the polling to make our webinar better. It will only take around 2 minutes, and we'll send the certificate to your email in 1 week time. There's only one question in the question and answer, which I think pretty important to be asked to you, Dr. Gentili, if you don't mind. One last question.
Mm-hmm.
So in your center, Professor, who's responsible for evaluating the post-operative DI and who's responsible for giving the DDAVP? Can a neurosurgeon evaluate the post-operative DI and give the DDAVP? I think this is very important for us.
Yeah, that's a very important question. And even in our situation, it's not 100 sometimes percent, certain. So you can have, you can either decide, and you can decide up front now, that just have the endocrinologist deal with major issues with DDAVP, whether craniopharyngioma, just say endocrinology, ask them right away, and then you don't have any problem, they look after it. In our center, because we do so many, as you see, you had, experience, Selfy and others, that we do so many of these that we can, handle a DI. Because we're confident in it. But if you're not, do not hesitate. I mean, to have your endocrinologist, if they have, or internist, whoever does the hormonal assays, do the DDAV, at least the replacement, whether it's steroids, thyroid, or DDAVP. So if you're very comfortable, if you're doing it all the time, well, hopefully you don't have DI too many times. But I mean, if you're comfortable with it, you can do it. But you have to understand, the issue. If not, getting an endocrinologist to follow the patient is not a bad idea. And particularly since in our cases, the patient is going to be discharged, and then follow up. As a neurosurgeon, you don't have necessarily time to follow them up in terms of their hormonal status. It's nice to have an endocrinologist then that will follow up them when they're discharged.
Okay, thank you, Dr. Gentili. And I think it's really good to have a strong team to take care of these patients, because I don't think we can take care of this kind of patient ourselves. And I'm very sorry, but there's one last question from Dr. Muhammad Kusdiansyah that raising his hand. You can unmute yourself. I think allowed to talk. Can someone allow Dr. Muhammad Kusdiansyah to talk?
Hello.
Yeah, okay, we can hear you.
Thank you so much. It's nice to see you again, Dr. Gentili. If you remember, I spent some time in your OR last year in February as an observer. It's such an amazing experience. My question may be similar with what being asked by other people, and maybe it have been asked over and over. So I understand from what I've learned, and also from what your lecture, that the result of the evolution is that you can choose objectively between the tools, or I said quote unquote, use them interchangeably, while aiming for maximal result for the patient. So what I get is that it is not a thing of transition or change, but more like an effort to add more weapon of choice to fight the diseases. So your philosophy of hybrid training is, for me, it's very interesting. Then my question is, how should we actually translate this to our training as young generation? Should we follow the same path of evolution and transition to hybrid, or in our training, or should we start to utilize all tools if available early in our training? And how early should we start? Thank you so much.
Thank you. Yeah, as I said, I had a whole talk on the issue of training of the skull-based surgeon in the future. But it's not only in our specialty, as you know, in terms of cerebrovascular. The issue of hybrid training is coming. It's coming also in thoracic surgery and endoscopic thoracic. So now we have, if you want to be a cerebrovascular neurosurgeon, you better learn interventional techniques, because the era of open, maybe not in Indonesia, but in eventually will come to Indonesia, it's all going to be really come down to interventional neuroradiology. So if you want to be a cerebrovascular surgeon, you're going to have to be an interventional neurosurgeon as well as an open neurosurgeon. You have to learn the open techniques as well as interventional. So in skull-based, it's very similar now. If you want to be a skull-based surgeon of the future, you must learn the endoscopic techniques. There's no question about that. But at the same time, as I said, you have to learn the classical open approaches that are still very important and will continue to be important. So how does that work? Well, I guess I can say, not that I want to say our group, I guess, has that advantage that, in Toronto, any fellow that comes to train with us will see we do many open approaches, and then we do endoscopic, so they're able to do both. So you have to try, and we're not the only one. There are other centers around the world. You should pick a center where you can see both the open endoscopic and learn both the open endoscopic approaches. Is that possible for everyone every time? I can't, maybe not, but to me, that's what I would do. If you're a young neurosurgeon starting out, you should see if you can do a fellowship in a place where they have both open and endoscopic approaches, a lot of pituitaries, and a lot of with ENT, so you get to see some ENT pathologies that I showed you in our cases.
Thank you, Dr. Kostiansa. Thank you, Dr. Gentili. So I think we are really over time. I'm very sorry for this, for everyone. This is very interesting. And yeah, I think we should really organize a 3-day course after the pandemic for you, Dr. Gentili. And thank you for all the panelists and participants. And thank you, Dr. Gentili, for sharing your expertise and wisdom and very interesting discussion. Before I close this session, I would like to invite Dr. Roland Sidabutar as the chief of our Skullbase division to give some words. Yes, Dr. Roland.
Yeah, thank you, Dr. Selfy. You hear my voice clearly?
Yes. Clearly.
It's very interesting discussion. Dr. Gentili is a professor. So I feel so sorry that we have to finish it because of the time and everything have something to do. So good evening, good afternoon, and good morning, everyone. Short introduce. My name is Roland. I am with Dr. Selfy, Dr. Agung, and Dr. Guata. We are in the Neuro-Oncology division and Skullbase in Neurosurgery department, Universitas Padjadjaran. Was very happy to host this webinar. So on behalf of our department, I am very grateful, especially for our special guest, Professor Gentili, Professor Goto, for taking your busy time, sharing valuable lesson and experience. We are very honored to have you with us. I think your talk and philosophy very enlightening for us. Thank you for that. I would like to thank also to our professor, seniors, and friend neurosurgeon from Indonesia, and our dear colleague from around the globe sorry I can mention you one by one. Very nice to meet you all. Thank you very much for being with us today. Thank you for your support. Last, for all national, international participant webinar, thank you for participating in this webinar. Hopefully you enjoy it, and we hope to meet you again in the next webinar. We also apologize to Professor Gentili if there are any inconvenient situation for you in this preparation of the webinar. Once again, thank you very much, everybody. Have a good night all, and back to you, Dr. Selfy.
Thank you, Dr. Roland. Okay, so I hope everyone is enjoying this session, and see you next time. Thank you, Dr. Selfy.
Very good. Thank you, everyone. Thank you. Bye-bye now.
Professor. Thank you, Professor Goto.
Enjoy the rest of the weekend.
Thank you. Thank you. Dr. Renindra, thank you.